Senior Officer optimizing ITN access projects, and he works for IFRC in the Health and Care Department in Geneva. So welcome, Robert.
Thank you, Jason. And thank you, Julian, for that wonderful presentation. So for this morning, we have a couple of presentations focused on country level experience sharing, where some of the countries who have implemented will share their experiences. For the first few presentations, we have presentation from the host country, Kenya. Dr. Kibor, can you please come forward? And then from Zambia, Jafat, please come and take your seat. So whilst they are coming, just to ask maybe, how many of us here have a mobile phone? How many of us have a mobile phone? So it tells you the level with which phones are available in country now. So roughly we have, in Africa, I think the latest population is about 75% access to mobile phones. And that tells you how much we can make use of mobile phones. So we are just at a stage where digitalization is really, really key that we focus on it. And although a lot of countries in the last 3 years have done this, we are also seeing a lot of lessons and challenges that we have experienced and a key lesson that we have shared. So these next presentations, they will share some of the lessons and also the opportunities that going forward we can use as we implement campaign digitalization. I'll hand over to Dr. Kibor from Kenya to start his presentation.
Well, ladies and gentlemen, good morning. I just want to start by expressing regrets from my senior leadership. We are having, there is an executive retreat led by His Excellency the President of the Republic of Kenya and the Deputy President, and we have our Cabinet Secretary as well as the Principal Secretary in that meeting, taking stock of the performance of the government. And yesterday, the Director of Preventive and Promotive Health, not yesterday, on Monday, as well as the Director of Primary Health Care, was to welcome you. So if you've not been welcome, I take this opportunity to welcome you officially to Kenya and Nairobi in particular. As my leaders would say, we take pride in this city, which has a national park in the middle of the city. So you should be able to travel around and enjoy some sites and visit some areas. There's a coastal city. We have quite a number of lakes in the Great Rift Valley. And I know when you are given security briefs, there are quite a number of some precautions, but I want to assure you that security and your safety is of utmost importance, and you are free to move around and enjoy quite a number of sites and sceneries in the country. So my name is Dr. Kibor Keitany, the head of the National Malaria Control Program. And as we talk about digitization process, I want to mention that we are in the process of mass net distribution campaign at the moment, which started at some point towards the beginning of last year, where macro planning did take place. And then up to September last year, we started the micro planning. Right now, as of from November last year, we launched our distribution campaign. The issuance of nets began on 15th November last year. We are targeting to issue out about 15.3 million nets. And right now we've issued so far about 2.1 million nets. And the process is ongoing. We have quite a number of teams in place. So perfect. Just to give you a background, 2006, 2007, that was the first time we did the mass net campaign distribution. where about 3.4 million nets were issued, which was an integrated campaign between missiles and provision of missiles vaccine as well as the nets. And in 2011, we went up to about 6.1 million nets, going to 2014, 2015, about another 10.1 million nets. 2015, 17, we moved up to 15.1, and 2021, about 16.8 million nets. And currently, we had projected initially to issue to give out 18.3 million nets, but because of some challenges and constraint, and as well as quite a number of other factors, we'll be giving out 15.3 million nets as planned at the moment. Just to mention that the first 4 campaigns, they were manual, which was represented by the picture by, I think, Julian, initially, but now we are digitizing most of the processes from registration of the participants to the beneficiaries and all the processes in between. And we are going to nearly paperless process, including the payment process. So some of the constraints that were noted in digitization time was that there were quite a number of loss of the data collected, so that by the time you want to issue, some documents are missing, inability to manage the participants. And the last item, which was presented in the picture earlier, great paperwork and accountability was becoming a challenge as well. Because in the registration, there are transcription errors witnessed. This is the historical process of the current digitization process, where early in 2022, immediately after the campaign of 2020-2021, we initiated the process of coming up with a digital system. And as you can see, that is where the conceptualization of the ideas came up, coming up with the specifications, community engagement, and coming up with and development of the process, which was quite an inclusive process. We have quite a number of partners involved, as well as the beneficiaries and the communities and the counties and the national teams. As of April 2023, that is when we pre-tested. We did a pilot in a small region in the country, where about, I think, 2,000 nets were issued, and then upscaled it to prepare for the next step. And some of the other things, including the payment, payroll system was incorporated. And later, during the launch of the MassNet campaign for the 2023-2024, we started with one county to check out. And this is where we gave out, we issued about 830,000 nets. And in this process, we had quite a number of challenges, which we improved in and subsequently moved to 2 counties. Just to give you a perspective, we have 47 counties in Kenya, the countrywide. So we started with 1. These are the administrative units of the country. And after the first county, we moved to 2 counties, and now we are doing it in 6 counties. And we hope we'll go into the 10 counties in the next step. Some of the areas that have been while working on this digital platform, there is the web-based platform, there is the short message system, and there is the unstructured supplementary SSD USSD code. And then we also have an app. So it applies in both areas where the mobile phone is not the advanced version. You have the USSD code. We can have the digital version, and we can also have the app. Some of the areas that have been digitized, from the user registration to household registration to keep the inventory of the nets, payroll management, and you are able to visualize the dashboards real time as issuance of nets takes place. This system has also been integrated with the LMIs, that is the supply chain system, so that there's near end-to-end visibility of the nets from the store up to where it's issued. Some of the innovations, the delegation from the national level, the registration can take place at the lowest levels of administration. That is what we call the communities, the community health units, who are led by what is known in other regions as community health volunteers or community healthcare workers. But here in Kenya, we call them community health promoters. These are the ones who do the household registrations. There's opportunity for data validation, and the bells are linked into the system, so that once the nets are opened, we are able to ascertain the number. I just want to highlight that this is a collaborative process where we have USAID PMI being part of the teams. We have the Global Fund team being actively participating in this process. We have the county governments. We have other government agencies, including KEMSA, that is Kenya Medical Supplies Agency. We have the National Government Administrative, and we have quite a number of third party, that includes the network providers being part of this process. And the campaign process, since the inception, we normally have meetings every Thursday to look in the progress. And these are meetings led by the principal secretary. And it has quite a number of stakeholders where we check where there are challenges, including in the digital platform, data validation, where action is needed and improvements are done accordingly. Quite a number of milestones that include real-time visibility during the launch of the MassNet distribution exercise. One of the first recipient was the governor of Homa Bay County. That was the first county. And we could see in the dashboard, once we issue that net, the stock comes down by 1, and it tells you the percentage of the nets as it goes down. And then there's comparison of performance across various regions. You can monitor the data flow and take action where you think the progress is not up to the standard. You can project, for example, we're using 5 days for household registration. So in the first day, if we notice that the rate at which it's taking place is not matching up to at least 30%, because that is, if we go for 30%, then at the end of 4 days, we should have reached quite a number. So we look at that target. Ideally, we hope in the future we should be able to reduce that to about 3 days, but now we are going by what was in the past. And there are quite a number of efficiencies that we have noted. We are able to track the nets where they are from and in the logistics process or the supply chain process. Quite a number of things that have been performed effectively is before an activity is started, we have to ensure that we have a master list where all the participants are in that platform. That is from the supervisors, those who will issue, and up to the beneficiaries. And then the commodity visibility, we have participant visibility. We are able to see who is performing, who seems to be absent in that process, and take necessary actions. And then providing feedback accordingly to the household. And eventually, when time comes now for the collection of nets, there is a reminder in the on the mobile phones, because the owner of the household or the household head is the one to receive the nets using the national identity card, but their mobile phone is also linked to that. So we activate a message that your nets are ready for collection. And quite a number of lessons is that initially when we started, our database was not up to the number, and the mapping was not in accordance. It was about maybe 30 to 50%, and we experienced quite a number of challenges. There was protracted timeline extension of timelines to clean the database and incorporate well mapping. But now we agreed that we need to reach at 95 percent validity of the data in the platform before initiating the process, so that there is no much work. Once it starts, it continues seamlessly. And we ensure that the database is complete and that they support supervision in all the stages in the subsequent events. Some of the recommendations is that, this is innovative process ongoing, but there are quite a number of suggestions. You want to get an excellent platform from the word go, which is not possible. So we want to check and get the minimum requirements for successful distribution. We may not want to go into the colorful image first, but at least focus on the essential areas, and that is getting, sorry, I think getting accurate implementation of the database, and then locking that system so that we improve step by step. That is what I was talking about. The scope of the implementation should be locked, and then now you make improvements with not changes that are necessary, so that it can be done after the end of the campaign for the subsequent one, including storage of this data, so that in the future we should not be starting, in the next 3 years, we should be doing another campaign. We should not be starting over the process, but keeping this data and improving on it, because there are not so many changes that might occur, but the changes, we are alive to the changes that may need to take place. Some of the challenges is that some of, the training, there are changes, these are mass process. Quite a number of people are involved. When one person is replaced, they need to be trained, and the technology human interface. Sometimes there are areas where there are network challenges, and the OTP may not come up back on time, but we've made necessary improvements so that an household, once you initiate the process, is registered, and moving or telling the teams to congregate in the areas where the network is the best. And of course, the mobile devices, but we are moving to issuing standard mobile phones to all the community health promoters. That is a national government agenda as well, to ensure that all community health promoters receive mobile phones and they do the mapping. One of the challenges in that is that, people, they were using their own mobile phones and they have their own activities ongoing. And sometimes, the memory of the phone, the message is coming, they need to delete some other messages so that they can take note of this. This is just a picture of during the launch. And it's a representative just to elaborate a bit on the picture. Yes. Unfortunately, oh yes, she's the governor of the county where we launched the MassNet distribution, the county head of health, and then we have representatives from the USAID, we have the Global Fund country lead, and we have our principal secretary in the Ministry of Health, and of course the beneficiaries and community health promoters. So that is the end of the presentation. I want to acknowledge the support of all these partners from the PMI, the Health IT, which is an implementing partner. We have the county governments and Mission for Essential Drugs. Thank you. And I want to state that I am the face of the presentation, but we have a team. As I've mentioned, it's a collaborative, and the questions we'll answer as a team. And if you want us to demonstrate later, this may not be the best time, but can be able to show that. Thank you, and over.
Thank you, and good morning, everyone. My name is Jafet Chwaula from Zambia, NMEP. So I'm glad to speak on behalf of the Zambian NMB for the Zambian ITN distribution digitization experience, and I'm glad to be here. So basically, thank you. So basically, Zambia is a malaria endemic with the prevalence of 29%. With that's from the last malaria indicator survey, and ITN use currently is the primary vector control intervention. And the last campaign that we did was in 2020. So basically, this campaign that we implemented last year is almost coming to an end. This year, I mean this month or next month, we should be able to conclude. And we're expected to distribute about 11.6 million nets, with of course 1 net per 2 people. And there are a number of partners, I think, that we had for the campaign. The PMI, we have the Global Fund, Against Malaria Foundation, just to mention a few, but I think there's a list even of other partners on the last slide. So the digitization campaign. So I know it sounds, I don't know, but it was one of the conditions, I think, which was part of the MOU with the Against Malaria Foundation, that they needed. Yeah, and I think which is good for the program. I think they pushed us to start thinking ahead in terms of digital aspect in the health sector. So they are supporting 6 provinces of the 10 provinces of Zambia. And we thought as a program to say, why should we only digitize part of the country and not just go throughout the country? So we as a program, we just decided, no, we are going to digitize all the 10 provinces of the country. So basically, that's what we did, that all the 10 provinces are on the digital platform. So in terms of this, so we basically, we embraced the innovation, and as mentioned, we went across all the 10 provinces, and the way it was implemented is that community health workers were actually moving in a pair, one using a paper register and the other one using a tablet or an Android phone. And basically, in brief, the digitization process involved procurement of a data server, which I think was procured through PMI, and also more than 10,000 gadgets for us to implement this digitization. So we did encounter some challenges prior to digitization for us to basically say, let's go the digital way. Paper-based, you go and look to verify the information using the registers, sometimes stone registers, sometimes moving the registers. These are huge and volume registers, bringing them to a central place. I think it was really a challenge, as well as we couldn't read. Different people have got different way they write. So there were all those issues, all those challenges. And also it was difficult to, for example, if there's a shortage of the LA lines, according to what they have planned as a district, for you to make those decisions promptly, it was proving to be a challenge until the campaign is over. That's when you are going to know that the number of nets that have been distributed are short compared to the registration on the ground. So there were all those challenges, as well as data entry in terms of validation, it was something that I think could take weeks and months for you to validate. So basically, this was just a synopsis of the digitization, looking at issues to do, the preparation, the household registration, the distribution, as well as the data integration. So these were just basically some steps that we did to ensure that we proceed with this digital aspect. So before we went ahead to digitize, I think there was during our plan of action for the mass campaign, we had some subcommittees. So there was an M&D committee that was part of the plan of action. So a small team was established to look into the technical aspects. I think we were on call with the team from AMF, Path Masepa, just to see which tool and system would be perfect for us to go ahead. So there was different platforms, the review platform, ODK, and also the DHIS tool, which were on the agenda to which one do we pick. So there were all these discussions looking at the pros and the cons of each of the system. And eventually we settled on using the DHIS2 tracker system, and that's currently what is running. So, and this was because it was accessible to users, both online and offline modes. Also assessment of assignment of unique household IDs by the system instead of the CBVs doing it manually. The integrated GIS capabilities to capture GPS coordinates of houses during registration, as well as the tracker configuration done on a development server. So basically the data that we are collecting is not aggregate data, is individual level data. At household level, even the household members are registered, and that is the information that we are collecting. So we thought that going the tracker way was better for the program. So, and data also is not only collected, as I mentioned, it's aggregated according to the highlights in the DHIS2 system. We know there's a province, there's a country, there's a province, there's a district, health facility. Under health facilities, there were zones as well as villages. Under those villages, now houses. So all this information was captured. All metadata configuration was done at national level, including accounts creation. And just to mention that before the digitization was done, actually we had a pilot in 6 districts last year. And from this pilot, we had a lot of lessons that we learned. And those pilots, the pilot district were selected by, in terms of network availability, we wanted to have a few of the rural as well as the urban. Also in terms of the population, those which have got huge populations, how long would it take, for example, to complete household registration? How long is it going to take, for example, when we are saying CBVs have to go there in terms of movements? There are some which are sparsely populated, some which are densely populated. So we wanted to have a feel of all those technicalities before we go with a full blown out digitization. So in terms of success or achievements, I can say that we successfully digitized the ITN campaign. Over 3 million households have been registered, and over 11.3 million nets are to be distributed. We enabled overall monitoring and supervision of households and distribution data regardless of location, and prompt feedback to lower levels was given, e.g. through WhatsApp group. The group is all the provinces, I can say, they are active on WhatsApp groups. They're able to go and ask, say, we are facing these challenges. So feedback is able to be given within a shortest period of time. This might be in terms of the overall campaign planning procedures. This might also be in terms of the technicalities that the provinces or the districts might be facing out there. Also, we supported over 10,000 CBV users simultaneously. So on the DHIS2 platform that we're using right now, more than 10,000 CBVs are active. So, and these are almost entering data at the same time. So the program and both at central level and also at lower levels, we've managed to support these CBVs in terms of whatever challenges that they may be facing. And also we managed to maintain at least 90% system uptime over this campaign during all these digitization process, from the planning as well as eventually the distribution. Then you can mention in terms of the political will from the government and active participation of all partners. I think the partnership came on board to support the government efforts, and this was one of the things that made it possible, I think, for us to even achieve what we achieved. And through training and field experience, we built capacity at provincial, district, facility, and community levels in digital tools and data capture. And this will also help us in terms of future campaigns, because at least we have a resource out there. We are not going to start from without. All logistics and commodities were mobilized, funds, cell phones, training material, and registers. Although delays occurred in some instances, the Ministry of Health and its partners stepped up also in monitoring, troubleshooting. The team was active, partner coordination to address all this. It was tough, but I think it was worth it. And we know that going forward, we have the experience in order to deploy as well as to implement one such campaign again. Once data capture has been completed, post-campaign assessment are expected to have enhanced transparency and accountability. And in terms of, it was not only the ministry which had the rights or access to the system. I think we created rights for almost all the partners. They're able to go in the system and see how the campaign is proceeding, including the AMF, PATHMA, SEPA, PMI, all the partnership had access just to see and appreciate how the data, because it's a live database, they can see how numbers are changing over time. Challenges. We can't say the digitization didn't have its own challenges. I think challenges were there. The campaign ran 3 months behind schedule into rain season, and we know what this entails. Throughout, roughly 20% of the CB data failed to upload to DHIS2. Management decisions had to be made using data from printed registers. So, as I mentioned, CBPs were moving in pairs, one hard copy register, one the digital tool. And we had to make decisions that they use the registers in terms of distribution as one of the two to say, these are the numbers to use for distribution. But in the background, they continued to upload the data in the system. So causes of the delay included late procurement or outsourcing of devices by MOH and other government departments. Yeah, we were late. So we had to start with 2 provinces. Then we went to another 3 provinces, then now the last 2 provinces. So there was that delay. So this was one of the issues. So it was like staggered when it comes to the trainings. Also delays in loading bundles by mobile service providers. I think this was a challenge. Sometimes they look, they have got too much capacity, but when you overwhelm them with 10,000 devices that you want to do, it became a challenge. So this is some of the things that we learned. Poor or no internet connectivity in rural areas. Some rural areas had to carry phones to a nearby health facility so that they're able to sync the data. And that was time consuming. Devices not sufficient charge to support a full day's work. So these were issues which were coming up in the field. DHIs to track a workload too complicated for CBVs, leading to skipping of critical steps. So these were also issues to do with the software that we had put on the devices. When they miss some steps, you'll find data on sync. So the team had to quickly move in and see from the system what data, what gaps, give feedback to the districts. Then they tell the CBVs. Release of a new version of DHIS to capture app in the middle of the campaign. That was a challenge. The DHIS2 was upgraded in the middle of the campaign. So if you find this data sitting on the tablets, that data won't sync if the CBV has allowed the device, for example, to update the version. So we had those challenges. We had to find a mechanism of getting that data through another device to upload it. DHIS to limit on number of events downloads affected distribution in some instances. Low GPS accuracy affected correctness of household positions. Inadequate technical skills at district level to fully support the facility and community levels. Also significant extra costs for procurement of devices, training, and technical support. Difficulties in establishing a daily work target for CBVs. These are community health workers due to geographical and population distribution. Dynamics, as I mentioned, other areas are sparsely populated, so you have to move, some CPBs have to move too many kilometers just to do some few works. Meanwhile, others are densely populated, making their work to be done within a shortest period of time. They don't need to work too many kilometers. Database grew to over 100 GB, making it difficult to back up regularly. So we also learned that we needed a very, very big server going forward. So these are general. The Zambian Ministry of Health and partners see digitalization as a way of the future and expect to reap rewards of improved efficiency. We can't take away from that. Thus, the main benefits from the 2023 campaign are the lessons learned, the best practices established, and the robust partnership that has been forged. We build local staff, IT capacity in districts, training them to troubleshoot and resolve IT issues without relying much on the central level staff. I think this is one of the main issues that we've taken forward and moving forward. Conduct a pilot to test device functionality, battery capacity, data synchronization, digital forms, etc. Develop a comprehensive budget and realistic timelines. I think this is very, very critical. I think we have learned, we always, in our meetings, we are always talking about the timeline. So if you ask me what is the best timeline of starting a campaign, I think I can try to guess slightly right now, based on this experience. So that anticipates all the costs, including all necessary accessories, transportation of devices to the sites, and redeployment after the campaign. So this is just one of the things. We thought when devices come, maybe a small Land Cruiser would pick the devices, take them to a next province. It was a different story. When they came, came with truckloads of boxes. You needed to hire like a big truck to take them. So it was a cost that we, for example, didn't anticipate. So we know moving forward, when registers came, they needed its own truck to be carried over. So these are some of the costs I think we had not anticipated, and now we know better. Also, plan to minimize data transmission bottlenecks in rural areas. The longer data stays on devices, the more challenging. So we have learned to sync up to the saver device plans for reaching places, but that are not covered by internet. For example, periodically collect devices from the community health workers and go and sync them. Log in all devices into the production server in advance on behalf of the community health workers. Don't expect them to go there, then they log in where there's no network. So it's better they are logged in beforehand so that when they go, households have already been downloaded and they can start the enumeration. Prepare strong training materials and job aids. So develop a troubleshooting manual after the pilot. As a program, we developed a comprehensive troubleshooting manual to address as commonly faced challenges. Also, we were using the explainer videos. Think on WhatsApp, the team would sit, they just develop a video, then they send it out there to the teams to with just basic steps that they are able, whatever challenges we anticipate, then we develop a video and just share with them. And also create WhatsApp group for communication with the teams just to see how we can help. So these are some of the quotes from the campaign that the team appreciated there at the lower levels, from the information guys as well as the district health directors, how efficient the system has brought to their districts or their work in terms of able to re-strategize and also efficiently allocate resources and also to plan their processing in terms of these movements. So these are the partnership, I think, that made the campaign a success. The Ministry of Health, through the National Malaria Elimination Center, the World Health Organization, the Global Fund, Path Masepa, Against Malaria Foundation, and last but not the least, the US President's Malaria Initiative. Thank you very much.
Thank you to Dr. Kibo and Jafat. We will take questions, comments. Any questions or comments? Okay. Can we have the... Yes, you can go first. You.
Thank you. My name is Parambir Gill. I'm with the Global Fund. First of all, thank you to the speakers and really, really, really rich information over here. Very heartened to see the systematic approach to the digitalization of the malaria campaign. Just wanted to ask a couple of questions. There was some really good feedback on the master data. Master data usually is an issue. So I was just very, very curious when we talked about 95% accuracy or completeness of the master data, considering that, the malaria campaign forms a very small part of the whole, let's say, portfolio of products that the full country has. So just wanted to see if there was any effect or learning from this, this effort that you did on master data on other data systems that you have in country, the ELMIS and the WMS and so on and so forth, and, health systems. On the data analysis and visualization, just wanted to have an understanding that what was, let's say, if it's for supervision, you'd have a shorter, loop. But if it was for the logistics side, from getting the information to making a decision to having an action, what was the time loop. And then it was very curious that the app had to be updated midway. Just wanted to understand that, the app definitely went through testing, went through training. So was any feedback taken regarding usability and timeliness of data capture during that time? And then what happened that that app had to be updated later on? Thank you.
From
Good morning to everyone. This is Lievin from UNDP Burundi. My question is going to Zambia. I noticed that, first of all, this digitalization option was a condition and was not a country option. So how did you adapt it to be convinced that it is a need, not a condition? And I would like to know exactly from the planning to the distribution date, how long it took. When we take into account all those constraints with these new tools, with that digitalization. Thank you.
I think you can also ask, sorry, the side first.
Thank you very much. I'm Dr. Pierre Nalinzi from Burundi. My question is for the first presenter. He said that among other advantage of digitalization is the efficiency and reducing of cost, of course. So have you done a study which shows that when we digitalize, there is really a reduce of the cost? Because according to the third presenter from Zambia, he told us that there is a significant extra cost. Those two presenters, they have the two different way to see how is the efficiency of the digitalization. Another question is for the NMCP Kenya. The digitalization, among different advantage, he said the real time visibility of data. So what option did they use during the campaign? Is it an offline option or online option? So if the two options were used at the same time, how did they manage to have a real-time visibility of data? Thank you very much.
You take one more question, then we allow them to answer before we go to the next round, please.
Thank you very much. My question is addressed on both countries. What is the most important details that lead you to take DHIS2 tracker or a solution based on USSD for doing your digitalization campaign? Why did you not choose existing solution like ODK?
I think we will start from Zambia. Can you respond to the questions?
Thank you. I will start answering. Then I think we have a team there. There is a team from Zambia. that has been part of this whole campaign. I think they'll chime in. Those are the experts as well who are there. So there was a question I'll start with the Global Fund. I hope I got the question right in terms of the time loop. In terms of the time loop on the decision, basing on the looking at what is coming online in terms of the visualization as well as the hardware decision, for example. I think that was an issue made. You have got data that is not maybe syncing. Now you need, for example, to distribute nets. I guess so. And it's like the system is a little bit behind in terms of the registers. I hope that was the question. So in terms of this, that what we were doing, because we knew that with these challenges, we anticipated that usually there will be this lag when we compare what is in the system with what is in the register. So one way that we did, I think we were having meetings almost every week. And we told the districts to submit information to us. We had information in the system. We could see what is in the system, but we didn't have information what is in the registers. So what we did is that on a regular basis, we used to tell them, submit to us information by health facility in terms of the numbers. For example, how many households have been registered in that health facility, how many nets, how many people and how many nets are required. So when they give us that information, even from the central level, we could be able to now see what is the difference, what is sitting on the system compared to what is in the actual registers. I think that's why we reached a point where we said, look, we have this information that is sitting on the registers, and this is also a primary data collection too, because what the person is recording on the phones is what is basically the same what is being recorded on, because these are going in pairs. So we were making decisions based on what is in the registers, because we could see the variance between what is in the registers and what is in the system based on those regular meetings that we were having. Then there was also a question in terms of the app was upgraded in the middle of the campaign. So what caused that? I think maybe I would allow Ruben to tackle that one. Then maybe, I don't know if you want to tackle it just now. Then I'll continue.
Yeah, sure. So our DHIS2 server was running 2.3.10 at configuration. And after we configured it, we tested it with 2.1.1.1 of the data capture app. So that's what we installed. That's what we tested and we are comfortable with. So that's the release we recommended. However, any other release that was released later on and then would be installed by the CBVs would somehow break. So that kind of caused that issues, because it was not something we had tested and approved at national level. But on the device, they could update. So that's what caused those challenges. It's because we didn't configure, our server was kind of tested and was working properly with a certain version, and then they would update it, and then, you know, an update would come with new features that may not really align with our server version.
Maybe you could also address why did we choose I know I presented it, ODK and not, I mean, the track and not ODK.
Okay, yeah, sure. So I personally has worked with ODK maybe for the past 6 years. It's a great tool. But I think it doesn't give us the visualization capabilities inbuilt as DHIS2 does. Also, the other thing was that the national program wanted a system that would easily integrate with the existing systems, which are DHIS2 based. So we are looking at that, and then using ODK means that we would have to do some engineering to move the data into the DHIS2 at the end. So we ended up settling for the DHIS2. Yeah, also I think at the point that we're doing that, because of how we wanted the distribution to happen, chances are, I saw a recent release with ODK where you're able to actually do follow-up on the same activity with two different forms. That wasn't there then. So we would have had to deal with the data that comes in and then another form, get it into another form for them to go and do distribution. So hopefully with the newer feature, that's something that would also be good to explore.
Thank you. Then there was a question from Burundi. Say why you were given this as a condition. So how did you adapt it to Benin? I think we looked at also the benefits. Even as a country, we are trying to go digital. So this was one of the low-lying fruits for us to start. We think it was part of the MOU, but think we were also happy to learn. We've been trying to say, no, how do we ensure that all our campaigns are digital? How do we ensure this improves, brings about efficiency as well as the other benefits? So think looking at the positives as well from there, it was not just dropped on us, but this is something that we deliberated on and we also adapted as a country. So that's how we made it now, not as a condition, but as also something that will be best practice for the program. Then there was, in terms of planning to distribution timeline, I think we started planning for this campaign late in 2022. And the first pilot we did was somewhere planning February, March, we had this pilot, but the actual implementation of the campaign started somewhere in July, August. That's when the training started. So in terms of the planning, I think planning had already started in 2022. So, but it is the first time we did it. Some of these issues, we missed them. So, but the planning started in 2022, though the campaign started in 2023. Then the Burundi said, Zambia said there were significant costs. I didn't say there were significant costs, but I said there were some costs that we didn't anticipate. For example, this transporting of these other logistical aspect. But that does not mean that it is, when you compare it with other campaign, that this it's more costly. Yeah, it can, because these things come with their own cost, but we didn't just plan for it. I think if we planned for it, we would have properly implemented or executed the assignment, but we had not planned. We didn't envision that, for example, tablets will come in trunks of trucks. We didn't anticipate that, and we didn't put a transport cost, for example, for transporting tablets. We didn't put that into our planning, but that does not mean that it was, yeah, it affected the campaign, but that does not mean that we can take away the positives from the campaign.
Thank you, Jafat. I think we'll give the opportunity for Dr. Kibo to also respond.
Thank you. Let's go straight to the first question, which I think is available for both of us on data. In the planning process, we had at the micro planning stage, where the various regions were bringing their data, we requested for data to be brought collectively from all the regions that will be, so that they are mapped according to from administrative or organizational structure of the digital system from the county, and then going to sub-county, going to the wards, going to the village and to the household. And we were using the top leadership. However, later we realized there are quite a number of challenges. We have a team called Community Health Assistants, or CHAS in short, that oversee community health promoters that who are essential in this process. So in the next stage of validation, we bring them on board to align the villages accordingly. And on the next question on the issue of before updating, we went through the whole process of development and, retesting and the pilot, as I mentioned, and even brought on board partners from outside to do ethical hacking and ensure the system security and safety. Before the next upgrades or updates on the system and new changes. The other issue I think has been handled by my colleague on efficiency. Of course, there are other costs that come in place, but it doesn't, in the cost benefit, if there is a cost of developing this system in itself, but that is independent cost. But when you look at the savings, for example, you make in reducing timelines, reducing the number of people you need in the field. For example, for us in the pilot stage, we needed 5 people in the registration, but later it's coming to 2 people, but we are foreseeing that we might even need 1 person for registration in the village. That is a significant cost when you're talking about, when you're dealing with numbers of over 10,000, 100,000 people. There is foreseeable significant cost. However, once we are done with the exercise, we'll be looking into the audits of this process. One of the other area is the real-time visibility of data. We were fully online, and that became a challenge later when in areas where the network is not good, and that is why we were coming to incorporation of the app process, the use of the offline versions, which we are still online version is still working quite well, and we have not really used the offline, but there is an option for using offline. There was real-time monitoring as well. I remember in one of the counties, we had 4 meetings in a day to follow up where are we moving, what are the challenges, and bringing on board the partners, especially in the network providers. If there's increase in bandwidth that is necessary, then it's done immediately. And as my colleague has mentioned, of course, there are unforeseen costs like the number of messages that are going out. That is a cost, but that is manageable if you look at the cost of the overall exercise. And there was real-time supervision, and then important details about using, a campaign process is versatile. It changes with time. There is need to include new system operators, people who are registering, which our routine data collection are quite rigid, input of data, output of data, but that ability to bring on board somebody else to register people and also to look at the flow of commodities, the number, the stocks where they're there, incorporation into the enterprise resource planning system, that is the ERP for payment system, for the LMIS for management of the resources, which is different from the routine data. And in this, what other system that is coming up in Kenya is the electronic community health information systems, which collects literally all this data that we need in MassNet. But at the development of this ECHIS, or electronic community health information system, was concurrent with the digital platform for malaria, that is the Digimal Kenya. But in the future now, we are working into looking into interoperability of the two, so that we have a campaign tool and we have the routine data collection tool for constant improvement. I believe those are in totality of the questions that came.
Yes, thank you to Dr. Kibwe and Jafat. In the interest of time, we will not be able to take more questions, but during the coffee break, please, you can see them and ask any further questions. Pardon me for that. Once again, we thank you for your presentation and also for contributing to the discussion. Shall we appreciate them as they take their seats? So coffee will end at 5 minutes to 11. Please, we have booths at the coffee area for the product solution partners. Whilst you take your coffee, kindly attend to them and learn more about the product. We will not have the chance to see all the products in the facilitated session. So use this as an opportunity to really learn more about the product and interact with them. Thank you.
Good. Well, it gives me great pleasure to introduce Ketty, who's going to be chairing our next session or managing our next session. And Ketty, as many of you know, is the principal ITN officer at the National Malaria Elimination Program in Zambia. So I'd just like to give a warm round of applause to Ketty as she starts. This one's, that's probably better.
Thank you. Thank you, Jason. Good morning once more. I hope we enjoyed our tea break and we did interact. So we'll proceed with our session. And in this set of session, we have 4 presentations. We'll have the first 2 from Mozambique and Togo. Then we'll have the last 2 from UNICEF and WHO. So to start with, I'll call upon the presenters. First, Mariana from Mozambique. You can come up, please. So Mariana will take us through some of the lessons learned from Mozambique, following the digitization and the vision for the future. And then we'll have another presentation from Togo. May we have Fazazi? Fazazi? Do we have Fazazi? Okay, so Fazazi will also take us through the digitization in Togo and also the using smartphones. So in the interest of time, as we are waiting for Fazazi to join us, I'll welcome Mariana to the floor. And Mariana, you're welcome. And you may introduce yourself and take us through the presentation. Thank you. Obrigada. Bom dia. My name is Mariana da Silva, and I will present on behalf of Mozambique NMCP team. It will be a session, a Portuguese-English session, so be patient. I will do my best to present in English. I will present the lessons learned from ITN campaign digitization 2022-2023 and the vision of the NMCP for the future integrated digitization. Okay, we'll start with a bit of context. So malaria in Mozambique is still a major public health problem. The prevalence in under 5 is around 32%. And we have the highest prevalence, about 55% in the northern province of the country. And we have the lowest prevalence in 2 provinces in the south, which is less than 1% of prevalence. So to deal with this burden, various malaria control and prevention strategy are being implemented in the country. We have ITN distribution in 9 over 11 provinces that we have. We implemented IRS in 5 provinces, but from this year, because of lack of funds, the number will be reduced to 3. We implement SMC in 1 province, and we had plans to expand for 1 more province. And also we implement PMC in one province. So the data quality is one of the priority for the NMCP. During the last National Malaria Strategic Plan, it was established a specific malaria data repository, which is called IMISH, and this was developed to meet complete, timely, and quality of all the malaria data available in the country. Regarding to the digitization, the first digitized campaign in Mozambique was done in 2021 during an emergency response in one of the province in Cabo Delgado province, where the team implemented for MDA campaign, and the app used at that time was ODK, and was all the data was visualized through the Power BI in daily data review forums. So because of this good experience, the NMCP decided to start the digitalization for other campaigns. And when he had this plan to implement the ITN's campaign in 2022-2023, a first digitized campaign with a national scope was initiated. So for this campaign, it was simultaneous registration and distribution. And the approach was door to door to cover over 6.2 million of households according to the micro-planning process. For this campaign, it was decided to use the DHIS2 platform because the data, the Ministry of Health data is running through DHIS2. And also the NMCP decided to implement a new platform, which was Digit by eGov Foundation. And the decision to use these two platforms was because both tools provide a mobile app with offline data collection capabilities, dashboards and data visualization, and the potential interoperability with the other national malaria information system that I mentioned before. So we can see in this map in which provinces we implemented DHIS2 platform in blue, and in yellow, I think we can see the provinces where we implemented the Digit platform. And what was the expectation on digitizing this campaign? One was to increase the transparency on how the results were obtained and by who, allow the users to track the campaign coverage and the user's performance. Two was to shorten the time between data collection and data review and analysis, and allow the teams to monitor low coverage areas, potential ITN stockouts, and poor personal performance. And three, we identify as one opportunity to collect data in this campaign and then to reuse for other campaigns. For example, with the geolocation, households, and demographic information. As you may know, the ITN campaign is a large and a complex process with many actors involved. For the process on this campaign, we had the household to be registered and the nets to be distributed. We needed to define the targets, to track all the logistics related to the ITNs and the other materials. We needed to to supervise all the process and to do the M&E for each steps. In terms of actors, we had at the warehouse level, logistics, warehouse at the level of the health system and also at the community level. We have community distributors to help us to register and to deliver nets. And we had supervision through the all levels, starting at the community level until the national supervisor role. And the M&E activities was coordinated through the specific TWG group, where was not only the Ministry of Health people, but the identified partners who made part to that TWG group. In terms of the process of the development, the M&E strategy, because this was a decision prior to the season of the campaign, the NMCP had opportunity to or have enough time to structure the specific M&E, consider this new tool based on the scope of the campaign to determine the M&E needs, identify all the M&E products, then define the indicators to be measured, the results and all the process around the campaign, and the opportunity to document all the defined activities, the indicators, the responsibilities, the resource and timelines in a comprehensive M&E plan. So at the end of this exercise, we had 24 core indicators across the campaign coverage, data quality, worker performance, supply chain, geo-registry, and also supervision. The three M&E outputs that were key to use during the campaign was related to the daily monitoring of campaign activities through the specific dashboard for both platforms, DGT and DHIS2. The daily reports coming with the specific indicators to track the key performance and timeliness of data. And at the end of the campaign, specific indicators to evaluate the reports through or from the provincial level. Now I'm going to share selected results from our campaign. So at the end, we felt that the campaign digitization was very positive in Mozambique because we saw a huge improvement on timeliness of data. We had more than 9% of records sent to the server on the same day of data collection, more than 90% records being synchronized by 7 p.m. during the distribution. Regarding to the teams, we had a concerns at the beginning of the campaign on how the digitization would impact and team's performance, but we saw that in all provinces exceeded the mean worker performance goal. It was defined to be 40 per day, but we see in all provinces it was more than 40. And it was possible to track across the supply chain all the nets used during the campaign. So we have here at the right down an example of one province where the register was very good meaning the consistency in terms of the initial stage at the district warehouse and the quantity of nets distributed at the household by the community distributor. We also had good results and consistency over a supervision goal. And we had more than 8% of visited households with associate GPS data. As I mentioned before, this is one of the information that we plan to reuse for the next campaigns. So at the end, more than 15 million nets were distributed with a coverage of 9% in the country. We can see in yellow, 2 provinces with low coverage, and these 2 provinces was the ones where the platform was initiated. We have Cabo Delgado, the first province where we implement DHIS2, and we have Tete province, the first province where we implement Digit platform. So at some point, being the first had some negative impact, but fortunately, we saw improvements in other provinces and the coverage was good. We have some key lessons to share with you. I will focus on 4. I think one is related on the dashboard. So we saw that the dashboard are most powerful when they are tailored to inform the decision of a specific user group. For example, below we have a team performance used during the campaign, where the first graph shows the total of visited households aggregated by supervisor. And then we have the second graph in the middle with the mean team performance by district to identify areas where the performance goal was not met. And then third one, we have display performance by named supervisor, which they didn't meet the expectation. And we even add the, it's difficult to see. We add some colors to identify names for specific supervisors that required more attention during the implementation. The second lesson was specific to the M&E structure. At the beginning, we tried as much as possible to use or to work within the existing M&E structure, forums and habits, and collaboratively shape these into the better version of themselves. Because we had the M&E before the campaign, we felt that the M&E and the dashboard use must be a core part of the training in digitized campaigns. And then the technical partners can help the NMCP to model how the M&E sessions can be held, but it's good to keep in mind that they have to passing the torch to the NMCP, and the focal point can continue to lead the M&E sessions. So by the end of the campaign, we had identified champions in each province, and then they had opportunity to share their skills and the all knowledge related to the data use through the platform. Different what was done in the pilot province, where we had the M&E sessions more than 8% led by the local partner. For lesson 3, it's important to have a strong governance structure at the implementation plans. As we all know, for the ITN campaign, we struggle with the reporting of stocks across the ITN supply chain. So we had challenges with the data completeness and accuracy specific for the ITNs. So unfortunately, not every ITNs could be tracked for the district warehouse to the household as we hoped at the beginning. During the implementation, we decided to include new user group and data collection instruments to try to solve this challenge, but the expectation was not at the same level that we had when we introduced these new tools. So although there was an excitement to digitize the entire ITN supply chain as a part of the campaign, the structure in place were not able to fully realize this vision, unlike the coverage indicators. As you can see in this image, we have differences between what was reported at the community level through the supervision, to the supervision lead, versus what was reported at the household level. The first lesson is regarding the documentation. As we prepare to operationalize this digitized campaign, we need to consider platform-specific quality control indicators, extensive fields validation and existence of version and specification and bugs through the platform. Not all recorded was possible to analyze through the platform, but fortunately it was less than 2% in over reports. Moving forward, we plan to assess the ownership and use of ITNs to evaluate the coverage after the distribution. So surveys are taking place in selected districts of 2 of our provinces. And the second one is they seek to evaluate the experience and the perception of end users and campaign leadership in relation to the both implemented platforms. So we conducted key interviews for key users identified. And the initial findings show more than 8% had a good or excellent experience with the digital tool. 9% found digital tool very easy to use, and visualize dashboards was done with about 9% of users, and more than 9% trust the digital platform to conduct these campaigns. So while the both platforms receive positive feedback, we need to highlight that results show a stronger use preference for Digit platform regarding the easy use of the system, ease of use, system performance, and user acceptance. However, they recommend or they want to see an improvement in its data visualization. And to finish, the Ministry of Health vision is to embrace all these this new chapter for all this innovation, and trying to engage other departments to do the same, such as NTDs and AP departments. And through the NMCP, there is a plan to integrate SMC and IRS campaign this year. Actually, we are now undergoing SMC digitized campaign. And the expectation is that using this, the same platform, we can minimize delays we can avoid duplication, we can use or reuse the same infrastructure, leverage past data, and harmonize coordination across procurement and the implementation process. I want to acknowledge all the listed here who made this vision possible, and this wonderful team who was involved in this digitized campaign. Obrigada.
Merci beaucoup. Bonjour à tout le monde. Je me présente. Je suis Batraoré Fazazi. Je représente le programme national de lutte contre le paludisme du Togo. Je vais partager ici avec vous une étape de digitalisation, mais je vais m'appesantir sur l'utilisation des smartphones de la communauté. Le concept Bring Your Own Device, que nous avons appelé Utilisez votre propre téléphone. Dans le plan, nous allons faire une introduction et faire une historique de là où nous avons commencé par la digitalisation. Là où on a commencé par la digitalisation. Maintenant, voir ce qui est comme bonne pratique dans ce que nous faisons dans la digitalisation au Togo et ce qui nous avait amené à le faire. Et enfin, nous allons parler des difficultés. Il n'y a pas une nouvelle approche qui n'a pas de difficultés et montrer ce que nous prévoyons gérer comme solution. Le Togo, comme vous le voyez, c'est un petit pays qui se situe entre le Ghana et le Bénin. Nous avons commencé la campagne à couverture universelle depuis 2011, mais avant 2017, la campagne se faisait manuellement avec tous les problèmes que nous avons commencé par voir depuis hier et ce matin. En 2017, nous avons fait une campagne semi-digitalisée. Semi-digitalisée veut dire quoi? Nous avons utilisé des registres, mais à la fin, ces registres ont été saisis en un point. Et en 2020, bon, par rapport à nos difficultés qu'on a eues en 2017, nous avons amélioré en utilisant d'autres plateformes mélangées. Vous allez voir ça là, dans la suite des présentations. Là-bas aussi, il n'y a pas sans défaut. Dans la recherche de l'amélioration, nous avons pensé à utiliser Dig2 à cause de, surtout, sa fonction d'interopérabilité et l'accès facile à tous les niveaux de la pyramide sanitaire du pays. Et je rappelle encore que le système national aussi est basé sur le DHS2. Historique. Ici, au fait, ce n'est pas cité déjà comme ce que j'ai déjà cité, mais c'est de vous montrer ce qu'on a fait à ces années-là. En 2017, comme je l'ai dit, c'est une semi-digitalisation qu'on a fait où nous avons servi uniquement que la campagne en utilisant les registres. Mais en 2019 et en 2020, vous allez voir, nous avons digitalisé toutes les étapes en utilisant plusieurs outils. Nous avons fait une application locale pour faire la micro-planification. Et pour la campagne elle-même, les supervisions, la distribution, nous avons utilisé ODK Aggregate comme serveur, mais le client est Kobo Collect. Cette approche aussi a montré ses limites parce que les gens n'ont pas accès à toutes les données C'est-à-dire, à tous les niveaux, on n'a pas eu accès aux informations pour faire l'analyse quotidienne. Parce qu'il fallait mettre un outil qui n'est pas facile à mettre à tous les niveaux. Donc, nous avons pensé, avec DHS2, qu'on peut avoir accès à toute hiérarchie sanitaire, à tous les niveaux de la pyramide sanitaire. Et c'est ce qu'on a fait en 2023. En 2023, vous allez voir ici, nous sommes partis loin. Puisqu'en 2020, on n'a pas digitalisé la logistique. Mais en 2023, nous avons commencé par la microplanification, la logistique, la supervision, les évaluations et la distribution elle-même. Tout est sur la plateforme DHS2. Ça nous a permis, à un seul point, de pouvoir comparer les données sans difficulté. On n'a pas eu d'efforts supplémentaires pour former d'autres personnes au niveau de district, formation sanitaire, même au niveau des équipes. Les gens étaient capables de regarder leurs données, comparer ce que j'ai reçu, ce que j'ai donné. Ici, ça nous amène à montrer ce que nous avons fait, ce qui nous a permis de pouvoir répondre à nos approches depuis 2017. Depuis 2017, on a remarqué, après un exercice, on s'est dit, nous voulons utiliser les smartphones. Comment le faire? On voulait se baser sur les smartphones que les partenaires ont déjà mis sur la plateforme, sur le territoire togolais, où les AIC utilisent. À la dernière minute, on se rend compte que tous ces smartphones ne sont pas en forme. Moins de 20% des smartphones sont utilisables. Donc, on s'est dit, nous-mêmes, nous faisons partie de la communauté. Qu'est-ce qu'on va faire? On a analysé, voir tout le monde utilise les réseaux sociaux. WhatsApp, TikTok, Facebook. Donc, il va falloir qu'on fasse une cartographie pour voir si dans la communauté, on peut avoir les smartphones. Et nous avons procédé à cette évaluation qui nous a permis de savoir qu'on peut trouver. Après avoir fait la cartographie, nous avons procédé à la mobilisation de ces smartphones. Comment nous avons fait? Nous avons conditionné le travail de l'agent de dénombrement de distribution sur la base de disposer d'un smartphone fonctionnel. Ce n'est pas forcément que lui-même il devait en avoir. Peut-être son enfant, parce que les agents de dénombrement de distribution, ce sont des gens âgés. Ils ont des étudiants à la maison, ils ont leur mari, ils ont leurs femmes qui ont des smartphones. Donc, quand vous utilisez, on dit quoi? Chaque jour que vous utilisez votre smartphone, vous l'usez. Donc, on a promis un prime d'amortissement de ce smartphone de 1 000 francs. Ce qui n'est pas sans difficulté. Qu'est-ce qui nous a permis? Là-bas, nous avons fait quoi? C'est une estimation globale comme ça. Mais c'est après avoir fait l'enquête, après avoir fait les campagnes, nous sommes partis maintenant à la recherche, vraiment si la couverture, la disponibilité d'Internet, de smartphones fonctionnait. Et on est parti au niveau de notre autorité réglementaire des télécommunications pour confirmer notre constat hasardeux, où on est parti chercher la pénétration de la téléphonie et l'utilisation des réseaux sociaux. Et les résultats nous montrent réellement ici que par hasard, le taux de pénétration de la téléphonie mobile est de 83,83% au Togo et l'utilisation des données mobiles, l'Internet, est à 64,3%. Quand on parle du taux de pénétration, c'est le nombre d'abonnements par population. Donc ça vient nous confirmer notre approche. Comment nous avons fait pour le schéma de mobilisation des smartphones? En fait, comme nous travaillons selon la pyramide sanitaire, le niveau central ne peut pas avoir une influence dans la communauté. Donc, qui est le premier responsable là-bas? C'est le responsable du district. Donc, nous avons envoyé une note signée par le président de la commission, le président de la commission nationale, qui est le secrétaire général, une note au district que nous voulons mobiliser les smartphones dans la communauté. Et à leur tour, ils ont envoyé ces mêmes informations aux formations sanitaires. L'AIC étant dans sa zone sanitaire, il est sous la responsabilité directe du RFS. Le RFS travaille avec les chefs de la communauté. Donc, pour faire ce travail, nous avons les activités qu'on appelle des réunions communales. Donc, à ces réunions, le RFS informe l'ASC que la condition pour faire la campagne est de disposer d'un smartphone fonctionnel. Comme ça, les gens vont se paniquer, on les a informés. Utilise ton propre téléphone ou utilise les smartphones d'un parent. C'est ça qui les a permis. Eux, certains ont pu acheter, certains qui n'en ont pas, et certains qui ont les parents qui ont utilisé les téléphones de leurs parents pour faire la campagne. Et en faisant cela, chaque jour que la personne travaille, on lui paye 1000 francs. Ça veut dire que pour 12 jours, la personne a 12 000. En comparaison de ce qu'on devait faire si on devait acheter les smartphones, on s'est dit, dans le meilleur des cas, on peut avoir un smartphone qui coûte 30 000 francs CFA. Pour la campagne 2023, nous avons utilisé 9 756 smartphones, c'est-à-dire les agents qui dénomment plus les agents qui livrent les moustiquaires, qu'on appelle agents livreurs. Eux aussi, ils utilisent les smartphones. Et comme ils sont dans la communauté, on a promis les motiver avec les 1000 francs. Donc, dans ce cas, si on devait acheter le smartphone, si on a la chance de trouver un téléphone qui fait la campagne à 30 000, le montant pour ce téléphone, le total sera à 292 680 000 francs CFA. Mais si nous utilisons les primes d'amortissement d'utilisation de smartphone, dans le pire des cas, c'est que la personne a travaillé pendant 12 jours. Alors que ce n'est pas ça. Nous avons certaines zones qui travaillent 4 jours, 2 jours, 3 jours. Ce n'est pas la majorité. La majorité ne fait pas 12 jours. Donc, quand nous avons pris le pire des cas, 12 jours pour faire notre évaluation, là-bas, on a combien? 117 millions, sont 12 000 francs. Et en comparant, en termes de coûts, on voit déjà ici que nous avons vraiment un choix éclairé à faire. Mais on ne se limite pas là. Il y a aussi, quels sont les avantages que nous avons? Il y a la responsabilité de chaque acteur vis-à-vis de son propre téléphone. Donc, le risque de vol et de perte quasiment nul. Donc, directement, la ligne budgétaire pour l'achat des smartphones est supprimée. L'absence de coûts directs liés à la gestion logistique. Nous avons vu des gens ici qui pensent déplacer les smartphones d'un district à une autre. À part ça, la gestion d'un smartphone d'une campagne jusqu'à 3 ans. Un smartphone qu'on achète maintenant jusqu'à la 3e année, je ne crois pas que ce smartphone sans utiliser va fonctionner. Ça, on perd beaucoup. Même si d'autres pays qui font presque la campagne sur les 3 années, c'est que sur 2 ans après, l'utilisation pour les campagnes, le smartphone ne sera pas très bon à utiliser. Et ça va renforcer aussi le sentiment d'appropriation de la campagne dans la communauté. Donc, le fait d'utiliser l'approche Bring Your Own Device a aussi d'autres difficultés que nous avons constatées, qui est une adaptation de certains smartphones. Il y a certains smartphones qui ne sont pas aux normes. Il faut les détecter et vraiment, si c'est possible, changer ou faire un truc. Ils n'ont pas le même modèle, même marque, pour dire que quand quelqu'un te signale un problème, pour que tu dises que, ah, voici la solution. La difficulté d'assistance à distance. Problème de performance de certains smartphones par rapport à la géolocalisation. La qualité de la géolocalisation. Un exemple, on a trouvé des ménages qui se retrouvent en Chine, certaines dans la mer au-delà du Brésil. Les défis que nous avons, c'est la maîtrise de l'application par les agents communautaires. Comme on les a pris, c'est une nouvelle application, comme on a changé, on avait ce défi-là, mais qu'on a pu gérer. Caractéristique pour la précision de la géolocalisation et minimiser les bugs de l'application liée au paramétrage. Avec différents types de téléphones, on doit avoir ces genres de bugs qui conflient entre le paramétrage du smartphone et l'application. Les leçons apprises, en fait, il y a l'adhésion. On a compris que la communauté s'adhère à la campagne et s'adhère à l'approche Bring Your Own Device. L'adhésion à la campagne d'aide responsable de district et d'information sanitaire. Et qu'est-ce qu'on a appris? Pour pouvoir détecter les smartphones, on a eu à faire des tests pilotes sur le plan national pour pouvoir détecter les niveaux de chaque utilisateur et quels sont les types de smartphones qu'on a sur le terrain pour pouvoir anticiper. Et on a déployé les techniciens informaticiens dans chaque région pour être plus proche des utilisateurs. Par rapport aux défis, les apports de solutions que nous avons envisagés, c'est de déployer les techniciens dans toutes les régions pour la gestion des problèmes liés aux aspects techniques. Achat de powerbank. Le fait que nous prenons leur smartphone, qui sait déjà parfois, on envisage acheter les smartphones pour les accompagner, pour que la personne ne soit pas embêtée par les décharges récurrentes. La reprographie de quelques feuilles. On a vu certains qui font digitalisation plus registre. Nous, on fait 5% des registres pour au cas où le smartphone se gâte, pour que la personne ne soit pas embêtée. Il revient à la maison, le technicien va récupérer le téléphone, il repart et il ressaisit les données. La présence du superviseur dans chaque équipe de zone pour faciliter la compréhension de couchettes que j'ai parlé hier. Et s'il y a un problème de manipulation, il a un niveau plus élevé que l'AEC, il puisse résoudre en attendant que le technicien ne puisse venir. Je vous remercie.
Thank you very much, Marianne and Fasazi, for those wonderful presentations. So in the interest of time, we'll get questions for this session. We'll only have 4 questions, 2 for Mozambique, 2 for Togo. So we'll start with this table here.
Merci pour la parole. C'est Nissi de la RDC. J'ai une question pour les 2 pays, la Mozambique et le Togo. C'est intéressant parce qu'ils ont eu à utiliser les 2 logiciels, ODK et puis DHS2, et puis Kobo Collect et puis DHS2. Je voulais d'abord savoir qu'ils m'expliquent et qu'ils me disent quel est le logiciel, par exemple, pendant la collecte des données vers le ménage, qui était plus facile pour les agents dénombrés, entre DHS2 et Kobo Collect ou ODK. Et puis, je voulais savoir si vous pouvez nous expliquer comment vous arrivez à nettoyer vos données quand vous trouvez des incohérences à partir de votre dashboard, quand vous voyez par exemple il y a des clés de répartition des ménages qui n'est pas respectées, qu'est-ce que vous faites pour aller corriger ces différentes données? Merci.
Thank you. We can have a question from you.
OK, merci. Je suis le docteur Kamara du Burkina Faso. J'ai une question pour chacun des présentateurs. D'ailleurs, je les félicite pour les présentations. La première question s'adresse à la présentation de Mozambique. Voilà, donc parmi les avantages de la digitalisation, donc elle dit que les données de la digitalisation de la campagne passée seront utilisées pour la prochaine campagne, si c'est ce que j'ai bien compris. Donc, je voulais savoir comment vont-ils utiliser ces données-là, étant donné qu'il y a des changements au sein de la population liés à la mobilité, liés aux nouvelles naissances qu'il faudra prendre en compte. Comment vont-ils réutiliser les anciennes données? Pour ce qui concerne le Togo, merci pour la présentation. Je voudrais savoir quel est le niveau des agents de santé communautaire à votre niveau et quel est le ratio technicien, informaticien, équipe de dénombrement? Voilà, donc une manière de savoir quel est le nombre d'équipes de dénombrement pour un technicien informaticien. Merci.
Thank you. So in the interest of time, we'll allow 2 additional questions so we can allow the presenters to respond. Maybe one from the back and the last one here. Thank you.
Thank you very much. I'm Grace Adair from the GHSC PSM project. This is a question for Togo, but it's, I think, more broadly for the community. As we move forward with advocating or discussing bring your own devices, are there any data security concerns with having people install applications and collect data on their personal phones? And what did you do to mitigate that, or what should we do to mitigate that? Thank you.
Merci au présentateur pour...
J'ai beaucoup apprécié la présentation de vous. Je crois que le processus de bonne forme a beaucoup d'avantages. Donc, ma question, c'est au niveau de, je crois que ça a été posé au niveau de la protection de données, étant donné que les agents collecteurs utilisent leur propre smartphone, ils vont repartir avec leur téléphone, incluant les données qu'ils ont collectées. Donc, qu'est-ce qui a été mis en œuvre pour la protection des données des personnes lors de la distribution? L'autre question, c'est concernant la qualité des données. J'aimerais savoir à quel moment les données sont checkées. Est-ce que ce sont les conseillers communautaires qui soumettent, après avoir collecté les données, soumettent directement les données au serveur, ou bien il y a un processus de vérification qui est en place avant la soumission des données? Merci. Je dois répondre, c'est bon? Okay.
Thank you. So for now, we'll allow the speakers to respond. Maybe we'll start with Mozambique. Thank you for the questions. Regarding the logistic question, we had the logistic was a very challenge for us, and was one of the stage where the funds were very needed. We decided to keep all the devices at the how can I say, at the sede distrital. We had all the devices here in one one point, and then we needed to take each day from the district capital to all areas. So hearing the Togo experience with the devices at the community level is something that maybe we can think in the future, because it wasn't an easy part for us to carry these funds at the beginning of the day to the community, and then at the end of the day, taking all the devices back to the capital, to the districts, to do the final synchronization and to identify some bugs or errors on the platform at the end of the day. So the process was this. And we use the DHIS2 and Digit platform, not Kobo. And we used these two because we had the same advantage in terms of collecting data in offline mode. So we didn't experience difference at the community level in terms of the data collection. So the performance was quite good for both platforms. I'm not sure if this was the question. In terms of the reuse of data, we identify the specific data coming through the geo coordination and also the number of the households, because it was door-to-door campaign. So our expectation is to use as a denominator all these community level data for the planification purpose. At least we have a proxy, a proxy denominator in comparison to what we have through the census. So now this is ongoing analysis in terms of how good this data is in comparison to what we have with the official department with the population data. So we still have a space to improve all this geo information and the household information. Thank you.
Thank you, Mariana. Over to you, Fassad.
Merci beaucoup. Je vais directement répondre à la première question par rapport à la facilité d'utilisation des ODK et les autres applications dans la communauté. En fait, devant la facilité d'utilisation des ODK par les AIC, et se trouve la chance de faire plus d'erreurs. On a rencontré beaucoup d'erreurs qu'on ne pouvait pas corriger. Et déjà, dans la configuration, on n'a pas les détails que nous avons pu mettre au niveau de la configuration, au niveau de l'élaboration des formulaires avec DHS2. Donc là-bas, c'est pourquoi nous avons préféré le DHS2. Mais en termes de capture d'informations, ODK, Kobo Toolbox, plus rapide. Mais en termes de correction des erreurs, c'est à la fin de la journée, chaque agent synchronise, il cherche un point où il y a une connexion. Heureusement, au Togo, la couverture au moins plus de 90%. Il trouve un point où la connexion est là, il puisse envoyer. Ou soit, s'il n'y a pas, nous avons plusieurs opérateurs. Si l'un ne couvre pas là-bas, l'autre couvre. C'est ce qui nous arrange. Et comment on fait? C'est le responsable formation sanitaire, en regardant le tableau de bord, on a mis des règles de validation qui sont là. Parfois, il y a des couleurs, parfois, il y a les chiffres qui dépassent la limite, qui montrent en même temps qu'il y a une cohérence entre ce que tu as rentré et ce que tu as cité. Et lui, il intervient auprès de l'équipe qui a fait le travail. Mais l'équipe qui a fait le travail n'a pas le pouvoir de modifier lui-même. C'est ce qu'on a fait. Maintenant, c'est le responsable de formation sanitaire, en respectant, il interroge le superviseur d'équipe, ils s'entendent sur l'erreur qui est passée et on passe à la correction. Il peut arriver aussi que ça échappe au responsable de formation sanitaire. Le responsable du district, le point focal district, peut remarquer cela et rappeler automatiquement. Ça peut l'échapper. Et parfois, il arrive que c'est le niveau central comme moi, en tant que gestionnaire des données, qui remarque, parce que c'est mon rôle de regarder, d'analyser plus profondément pour voir les normes qu'on a mis en place, pour pouvoir interpeller jusqu'au niveau le plus bas possible. Le Burkina Faso demande le niveau des AIC. Le niveau qu'on a demandé, c'est de savoir lire et écrire. Mais il y a parmi nos AIC les gens qui ont le niveau bac. Il y a ceux qui ont le niveau BPC. La majorité ont au moins CPD. Pour les sélectionner dans la communauté, le chef du quartier du village doit s'assurer que la personne sait parler, lire et écrire. C'est la condition qu'on a mis en place. Le ratio technicien et agent dénombreur, en fait, la formation qu'on fait avec l'approche que nous avons fait, en fait, on renforce la capacité des équipes cadres du district, des régions, même le RFS, pour être capable de résoudre les problèmes logiques. Mais c'est les problèmes techniques que l'informaticien est censé aller. Donc, avec les outils que nous avons mis en place depuis, on n'a pas trop vu ce genre de problèmes. Les rares problèmes qu'il y a, il suffit qu'on appelle au téléphone, on puisse indiquer le RFS, il corrige toujours. Mais là où ça dépasse le RFS, il y a le déplacement qui est nécessaire d'aller au niveau district. Donc, le RFS ramène le truc, le smartphone là-bas. Mais deuxième option, c'est que le technicien fait des supervisions chaque jour. Si aujourd'hui je vais vers l'est, demain je vais vers l'ouest, puis le sud. Ou bien la nuit, on m'a signalé un problème dans une zone, c'est là-bas que je privilégie pour aller. Dans la supervision quotidienne aussi, le niveau central a un niveau plus élevé, même bien qu'ils ne sont pas informaticiens, ils ont la capacité de gérer quelques problèmes techniques parce qu'ils manipulent eux-mêmes leur smartphone chaque jour. Ils règlent eux-mêmes leurs problèmes et parfois ils gèrent ces genres de problèmes. C'est cette gestion efficience-là qu'on utilise. On donne la capacité aux équipes régions, districts, niveau central de pouvoir gérer ça. C'est au cas où on ne peut pas, l'informaticien intervient. Les problèmes de sécurité des données, effectivement, que ce soit au DK, quand on envoie, c'est vrai, on pense que les données ne sont plus lisibles. Mais quand il s'agit d'un informaticien, il sait comment aller prendre un fichier sur le device pour faire ce qu'il veut. Mais nous cherchons les moyens, parce que la chance qu'on a dans la sélection, dans la formation de l'AIC, on parle de délégation des tâches. Et histoire de ce qui est d'information est déjà impliqué dans leur tête. Quand je sais que mon outil de travail, c'est ça. Quand il prend le téléphone de sa soeur, de son parent, à la fin de la campagne, c'est lui qui vient au niveau du responsable de formation sanitaire. On vide, on supprime l'application et il part avec son smartphone. Mais pendant la campagne, le téléphone est là avec toutes ces informations. Bon, j'avais déjà répondu à quel moment les données sont envoyées. C'est chaque fin de journée, mais il arrive dans les points où la connexion est difficile. Il y a des zones à conflit où parfois la connexion est coupée carrément. La personne fait la campagne jusqu'au nombre de jours qu'il est prévu faire. Il finit maintenant, il vient à la formation sanitaire pour pouvoir envoyer les données. À ce moment, on connaît ces zones-là, donc l'analyse se fait sans ça. Mais comment on corrige? Pendant la campagne, on a 12 jours. Donc, 4e jour, on a ce qu'on appelle monitorage à mi-parcours. Pendant cette monitorage-là, celui qui est dans des situations difficiles d'accès revient pour qu'on puisse gérer son problème et on corrige cette information-là. Merci beaucoup. Je crois que j'ai épuisé les questions qu'on m'a posées. Oui, c'est ça que je dis. En fait, quand l'ASC collecte l'information, à la fin de la journée, il synchronise l'information. Mais la donnée est toujours sur son smartphone parce qu'on peut l'appeler d'aller corriger l'information. On peut l'appeler, on peut venir chez lui, pouvoir interagir sur le smartphone. Donc, on ne supprime pas les données. C'est ça que j'ai dit. En termes de formation et de leur acquis, le secret d'information est déjà inculqué. C'est quand il utilise le téléphone de quelqu'un d'autre que parfois, à la fin de la campagne, il est obligé directement de venir pour qu'on puisse supprimer l'application. On désinstalle l'application du téléphone. C'est ça. Maintenant, quand on finit maintenant, l'administrateur bloque la synchronisation des données sur le serveur. Aucune donnée n'est plus transférée après le 12e jour. En fait, c'est les mesures là qu'on a mis. Merci beaucoup.
Thank you very much. And we would not take another set of questions, but please let's feel free to interact with the presenters. So for now, a big round of applause to the presenters as they leave the stage. So we'll now call upon the next two presenters. One is from UNICEF, Christina. So Christina will take us through the integrated digital microplanning for immunization. And we'll also have another set of presentation from DSA, from WHO, who will take us through the regional service support services, mapping, impact and surveillance. Thank you very much, and you're welcome. Over to you. We'll start with.
Is that somewhere where I can check the time? Somewhere where I can check the time? Oh, you just asked. Morning, everybody. My name is Cristina Luciana, and I work at UNICEF as health specialist supporting campaign digitalizations. And thank you. Okay, thank you so much. And today I will show a presentation in collaboration with my colleague, Abundo, on the use of integrated digital microplanning for immunization campaigns. In 2018, UNICEF adopted a digital health vision. UNICEF came up with a vision statement, and I'm not reading it all, but I just want you to understand that the reason why UNICEF has adopted a digital health vision is because we strongly believe that when countries adopt a digitalization approach, there is an opportunity for better decision making. So the focus of the digital health vision at UNICEF is to make sure that the data and the digitalization effort actually is used to improve health outcomes. We are switching gears a little bit here because all presentations were on malaria campaigns, while UNICEF does malaria campaigns, but also immunization campaigns. And for this, we align with the Gavi digital health information priority areas. And specifically, there are several areas where UNICEF contributes to Gavi digital health information priority areas. And today in this presentation, we'll look at 4 areas, the ones highlighted in blue. Let's start with the first one, and it's about the geospatial population estimates. And I want to emphasize that UNICEF mainly does geospatial population estimates to support immunization campaigns. However, geospatial population estimates can actually be used in any type of campaigns, including integrated campaigns, because the moment that you have teams that go out and look at data from a field work planning or microcensus and go through geospatial covariates generation and analysis, and also work to modeling and estimate populations, the results of these efforts can actually be applied to any type of campaigns. In 2024, UNICEF will support the geospatial population estimates in the countries listed here. And the output of this exercise is to basically provide an overview of population estimates, very detailed, overlaying several data sources that are already available or that will be made available during fieldwork planning. One of the uses of the geospatial population estimates is to support the digital micro-planning of campaigns. Again, I'm talking about immunization campaigns, but it can be used for any type of campaigns. So basically, before an immunization campaign or a malaria LLIN campaigns, it's important to know where you want to go, where you want to distribute your health commodities, whether they are mosquito nets or deworming or nutrition supplements or vaccines. And you want to make sure that this information is used to plan the campaigns. That means how many field workers we need, where are we delivering the health commodities? Is it door to door or is it at specific distribution centers and so on? And UNICEF has quite a lot of experience in this area, and specifically we are working to develop a geo-enabled micro-planning handbook that might support countries to navigate what it takes to, once the data is available, to go through a digital micro-planning for the campaign. Okay, another area where that is closely aligned with the digital health vision at UNICEF is real-time monitoring, or RTM. I will not go through the details of these because we are all familiar with the value of real-time monitoring and why we are digitizing health systems, because we definitely see the value in having real-time data to inform better decision-making process. And ultimately, this will give us an opportunity to for using data for corrective actions. And we want to take it a little, we want to take this a step further because we know that there's value in real-time monitoring, and we know that once done properly, we use the data to inform better decision-making, and ultimately this will give us evidence, for example, improved accountability and quality of vaccination campaigns. However, we don't want this to be another parallel system or a siloed approach. So we are also working to integrate these efforts into current digital ecosystem or HMIS platform. And these real-time monitoring exercise can actually be done at different phases of the campaign, during the planning phase, during the implementation of the campaign itself, or after the campaign. And we've seen several examples from other presentations this morning in the value of using data also at the end of the campaign. There is also a theory of change related to real-time monitoring. I've basically touched already on several of these things. So basically, here we make the case of what it takes in terms of inputs and what it will ultimately deliver in terms of outcomes and impacts. So when we made available data in real time to decision makers for making sure that we have a list of corrective actions. Since okay, and it's not going. Okay. In the past, I would say 5 to 8 years, there have been several use cases on the use of real-time monitoring during campaigns, several types of campaigns. And as you can see, countries adopt digital tools to support real-time monitoring based on what it makes more sense according to the country digital ecosystem. So we have countries who are using DHS2, Copo Collect, ODK, RTVAMA in the Philippines, or other tools. And my colleague Wabundo will walk you through one of the tools that we use a lot with countries at UNICEF, that's Rapid Pro.
So Rapid Pro is an open source software platform that allows users to easily scale and build messaging and notification services. As a brief video here to walk you through Rapid Pro. The sound is. So I guess just as it's playing out, I can talk through the video. Rapid Pro has been
and collaborate directly with the most important and often. Rapid Pro is an open source software that allows you to easily build and scale mobile-based applications from anywhere in the world. Rapid Pro powers the way governments and development partners connect, engage, and collaborate directly with the most important and often most marginalized voices in their communities. Although Rapid Pro can be used across a wide range of sectors, it is a particularly powerful tool for international development because its common platform makes it easy to adapt applications for different contexts and needs. From empowering youth in rural villages to report issues in their community, to facilitating exchange of best practices among teachers, to sending prenatal care tips and reminders to mothers, Rapid Pro provides an open source software solution for mobile-based services worldwide. Rapid Pro can power the connection between government leaders and the most important voices in their countries, while allowing organizations to connect those voices across borders and geographies. Anyone can use Rapid Pro without the need of a programmer or external technical support. Using Rapid Pro's Flow Builder, you can quickly build, test, and monitor communications and better identify and respond to needs in real time. What are you waiting for? Get started using Rapid Pro today.
So I'll walk you through an example of how Rapid Pro has been used in a vaccination campaign. In Malawi in 2022, Rapid Pro was used by community vaccinators to report aggregate data from their campaigns daily. And as you see in the middle where the mobile phone is, they receive prompts to be able, and then they submit the aggregate data. Also at the national level, they were able to reach out to the vaccinators by sending them broadcast messages or letting them know when they were delayed in submitting their data. Rapid Pro was also used in conjunction with DHIS2 tracker, so the two data sources were combined in order to get an overview of the vaccination campaign. In order to integrate data from real-time monitoring into national health systems, one of the steps we've taken is to build a connector between Rapid Pro and DHIS2. And this means that aggregate data connected using Rapid Pro can be submitted to DHIS2. There had been other connectors built in the past in Uganda, Rwanda, to name a few, but they were all custom made. And now this connector is widely available and open source for anyone who has an interest in using it. It was piloted in Zimbabwe, and in Zimbabwe, it was used to submit aggregate data from the field into Rapid Pro. Into DHIS2. The next steps for this perhaps would be looking at individual level data, so submitting individual level from Rapid Pro to DHIS2, and that will be phase 2 of the connector that we're currently scoping and looking for investments in.
So in terms of guidance that UNICEF is offering, we are currently developing on a new campaign digitalization package. We have already several tools and experience out there, and we are looking to package a guidance on how to effectively use RTM approaches and campaign digitalization approaches to countries. And the purpose is to do this agnostically in terms of tools and agnostically in terms of health area, either malaria or immunization or anti-Ds. It will be a coordinated efforts with several partners who are in this room. And the objective is to make sure that we'll have the opportunity to provide guidance on some commonalities in terms of campaigns and also on some specific use cases that we have when it comes to campaigns. So let's think of, for example, anti-Ds campaigns where there is the need for longitudinal tracking or refer patients to nearby health facilities. So pulling it all together, as I've said, we will work with the partners to agree on a shared vision for a campaign digitalization approach. And we are working on a campaign digitalization framework to map the steps that countries and implementing partners need to go through in terms of what it takes to digitize campaigns. And this is something that we have in the back of our mind. I'm not sure we'll be able to, maybe this year we'll start with a couple of pilot and then we'll see how this goes. But there is an opportunity thanks to more sophisticated technologies, one for all artificial intelligence, to automatize decision-making processes. So we are also looking into these and see whether there is a value to apply algorithms or artificial intelligence to provide more actionable insights and automatize the decision-making process that comes after a digitalization effort. Thank you.
Morning, everyone. My name is Jesse Yumba. I'm the Spend Collect Project Officer within WHO Africa Region Office. I will talk about Spend Collect, a tool for advancing entity digitalization in mapping, impact surveillance, and coverage survey. My presentation is written in English, so I will do it in French. OK, les points abordés sur la présentation seront qu'est-ce que Spend Collect? On parlera aussi de l'expérience des enquêtes de couverture avec le Soudan du Sud et le Burkina Faso. Et ensuite, on parlera des futures améliorations sur les services offerts par Spend Collect. Qu'est-ce que Spend Collect? Spend Collect est un service dédié au programme manager Entity, désigné pour faciliter les enquêtes entomologiques et épidémiologiques sur la filariose lymphatique, l'onchocercose, la schistosomiase et les géohelminthiases. Il apporte le support dans ces enquêtes pour toutes les étapes, que ce soit les étapes qui viennent avant les enquêtes, telles que la révision des autorisations éthiques, la révision aussi des protocoles pour être sûr qu'ils respectent les standards de l'OMS, pendant les enquêtes aussi, avec des formations qui sont organisées avec les pays, avec aussi l'assistance pour la création des formulaires électroniques et aussi les tableaux de bord qui sont destinés à la surveillance et assurer une bonne qualité de données. Et les étapes aussi qui viennent après les enquêtes, telles que la génération des formulaires de rapportage de données, appelés EPRF. Quand est-ce qu'on a besoin des enquêtes? Dans le cas des maladies tropicales négligeables, chimiothérapie préventive, nous en avons besoin avant pour les cartographies de base, pour désigner les zones endémiques, pour organiser les traitements. Nous en avons aussi besoin après les distributions de masse des médicaments, pour avoir la couverture de distribution. Et nous avons aussi lors besoin des enquêtes d'impact pour voir si l'endémicité a réduite ou si la maladie est éliminée, ce qui est nécessaire lors de la soumission du donné pour dire que la maladie a été éliminée. Comment fonctionne Spend Collect? L'utilisation d'Espen Collect se fait en 5 étapes. La première étape est l'enregistrement au niveau du portail Espen. Une fois que l'enregistrement a été fait par le pays, la deuxième étape est la formation. Cette formation est organisée avec le ministère de la Santé et le partenaire. Une fois que les formations ont été faites, la prochaine étape est la collecte des données. Pendant la collecte des données, nous assistons aussi les pays pour assurer une bonne qualité de données. Et une fois que les données sont nettoyées et de bonne qualité, nous assistons les pays à générer le rapport épidémiologique qu'ils devront valider et soumettre officiellement. Où est-ce qu'Espen Collect a été utilisé? Le service a été lancé en 2018 et de 2018 à 2023, le service a été utilisé dans 32 pays de la région africaine pour un total de 162 enquêtes. Et pendant ces enquêtes, plus de 2000 personnes ont été formées. Il y a aussi une possibilité d'intégrer des données épidémiologiques avec le système d'information sanitaire. Cela peut se faire à travers des API ou encore à travers manuellement en utilisant des moteurs d'intégration. Je vais maintenant parler de l'expérience de l'enquête de couverture avec le Soudan du Sud et le Burkina Faso. Les enquêtes de couverture sont des enquêtes qui se font après la distribution de masse de médicaments pour déterminer le pourcentage de couverture dans différentes écoles et différents villages. Le premier cas, c'est pour le Soudan du Sud. L'enquête de couverture s'est passée entre octobre et novembre 2023. 100 personnes ont été formées pour cette enquête et 258 écoles ont été visitées. Un total de 8000 élèves ont été questionnés pour voir s'ils avaient effectivement bu les médicaments et 43 téléphones ont été utilisés par le Soudan du Sud. Le deuxième exemple, c'est le Burkina Faso. L'enquête s'est passée en décembre 2023. 20 personnes ont été formées pour cette enquête et 10 écoles ont été visitées. Dans le cadre de cette enquête, plus de 2000 élèves ont été questionnés pour savoir s'ils avaient bu les médicaments et 3 téléphones portables ont été utilisés. Quelle est l'assistance qui sont apportées durant ces enquêtes? Le premier, comme je l'ai dit tout à l'heure, c'est le protocole qui est examiné par des experts pour être sûr qu'il est conforme aux recommandations de l'OMS. Le deuxième point, c'est l'assistance à l'utilisation d'Espen Collect. Cette assistance se fait dans l'utilisation de l'application et aussi pour l'organisation des formations. Ces formations se font généralement à distance, mais pour des pays qui n'ont aucune expérience sur les collectes des données mobiles, nous pouvons aussi envoyer des consultants sur place pour qu'ils les assistent. L'assistance est aussi offerte pour le développement des formulaires qui seront utilisés lors de l'enquête et aussi pour le monitorage, pour être sûr que les données qui sont envoyées sont de bonne qualité. Nous utilisons un tableau de bord lors de l'enquête auquel les superviseurs et plusieurs acteurs ont accès pour être sûr qu'on a des données de bonne qualité lors de l'enquête. OK. La valeur ajoutée, c'est que nous avons la génération de l'EPRF qui peut être aussi un peu compliquée pour des pays qui n'ont pas les capacités techniques. L'autre aussi, c'est pour la montée en capacité du pays, puisque nous formons le pays pour donner l'expérience avec la collecte de données par molide. L'autre avantage aussi, c'est dans le cas des enquêtes de surveillance. Une surveillance, les résultats de cette enquête permettent de voir l'endémicité et les pourcentages de couverture de traitement. Et aussi sur la qualité de données. parce qu'on est sûr d'avoir des données de bonne qualité à la fin des enquêtes. Quelles sont les futures améliorations? La première amélioration, c'est l'étude est en train faite pour pouvoir apporter le support sur les campagnes de distribution de médicaments dans le cadre des maladies tropicales négligées à chimiothérapie préventive. Cela pourra se faire en utilisant, par exemple, une combinaison des registres au niveau des centres de santé. Et cela se fera aussi grâce au système d'information sanitaire. Et l'amélioration suivante, c'est la standardisation des données qui sont collectées par Spend Collect au niveau de systèmes d'information, au niveau des systèmes d'information sanitaire. Bien qu'il soit possible d'intégrer les données collectées par Spend Collect, il n'existe pas encore des modèles standards. Donc, une étude est en train d'être faite avec le Bénin pour intégrer les données, toutes les données qui ont été collectées avec Spend Collect dans leur instance DHIS2. Et en fonction de cette étude, on pourra définir un modèle standard d'intégration des données collectées par Spend Collect au niveau des instances DHIS2 des différents pays africains. C'est là que ma présentation s'arrête. Merci.
Well, thank you very much to the three presenters. I see we have a bit of time. We'll take a few questions. Please, let's ask the burning questions. If you have 4 questions, pick 1 or 2. You can't ask everything so that we can get the most out of the presentations. So we'll have first 6 questions, 3 for WHO and 3 for UNICEF. At the far end there.
Bonjour, merci pour la présentation. Ma question s'adresse à WHO. Alors, pour SPN, j'ai vu sur la carte qu'il y avait la Centrafrique. Vous pouvez un peu parler de ce que vous avez fait là-bas, si possible. Merci.
Thank you. Here.
Merci beaucoup pour la parole. Je réponds au nom du docteur ingénieur Julius Nyongabo du Burundi. Ma question, sinon mes observations sont adressées à Madame qui a fait la présentation au nom de l'UNICEF. Je me permets justement d'agir parce que au Burundi, en 2022, nous avons fait une petite expérience sur la microplanification basée sur les systèmes d'information géospatiale. Et là, le premier défi auquel on s'est heurté, c'était un défi lié à la disponibilité d'une image satellitaire à jour. Évidemment, de notre côté, on avait travaillé sur une zone pilote et nous avons eu la chance d'avoir Action Map qui nous a fourni la partie de l'image satellitaire sur la zone. Et on avait aussi rencontré notre défi sur les limites administratives qui avaient un certain décalage. Mais par après, justement, nous avons été obligés de refaire nos limites administratives et aussi adapter les aires de responsabilité à ces nouvelles limites. Et là, ma question, si justement on adopte une telle approche, parce que nous avons vu chez nous que ça apporte des résultats vraiment escompté en termes de la population estimée, comment est-ce qu'on peut avoir accès, un accès facile à ces images-là satellitaires? Merci.
Okay, thank you. Thank you for your presentation, UNICEF. So I want to ask about the Review Pro that you presented. So you mentioned you use Review Pro for your individual level data and then use connector to pull it to DHI. So I'm wondering why, since, can you get the question? Can you hear me? Can you hear me? Can I go ahead? Yes. Okay, thank you. So my question is about the presentation on Review Pro, which you use to collect individual level data and then use the connector to integrate it into DHIS. And I'm wondering why, what was the design thought process into that? Since I know that DHIS has data model could provide you all of those options. So why do you need to go through the route of having to move those data into DHIS using a connector, and what's the efficiency in that whole design data movement process? Thank you.
We'll get one last question. Okay, any last burning question? Okay, we can have responses from the presenters. We'll start with WHO.
Thank you very much. La question sur l'utilisation des spend collects en République centrafricaine. L'utilisation des spend collects en République centrafricaine était lors du début du lancement du service. Nous avons assisté la Centrafrique pour 3 enquêtes de cartographie. Ou plutôt pour préciser, en fait, il s'agissait d'une enquête de cartographie intégrée sur la filariose lymphatique, la schistosomiase et les géoalméthiases. Si ma mémoire est bonne, cette enquête s'est passée entre fin 2017 et début 2018. Merci.
Thanks for the question from the colleague from Burundi. So it's a two-part question. So I'll start with the last one. So how to overcome challenges in terms of thank you. How to overcome challenges in terms of better definition of administrative limits. So we are working on that in terms of definition of local geography. What are the terms that we use to define geography at local level? Because what we mean by village or what we name villages might not be the same at community level, at district level, province level, and then all the way up to central level. So there's some work specifically on local geography to overcome this challenge. And then for the other questions about access to satellite images, I know that there are some repository, and I will be happy to put you in contact with the person at UNICEF who's responsible for GIS, because I'm sure that he will be able to support on providing you access to a repository and other sites that can actually offer satellite images, including for Burundi.
Thank you. So I had the question about the Rapid Pro DHIS2 connector. So at the moment is aggregate level data, not individual. And also the reason why the connector was needed was that the the community health workers or the vaccinators were already recording some of this information on paper. They didn't have access to DHIS2 themselves, and they also didn't have the tracker on their phones or apps. So Rapid Pro allows them to send SMSs or WhatsApp messages or whatever messaging tool already exists on their mobile phone. They use that to send out the aggregate level data, which is then pushed to DHIS2. So I'm not sure if that answers your question, but that was the reason, is that you don't need an app for Rapid Pro. You just need a phone with SMS or whatever your preferred message communication channel is. Thank you. I can take one last set of questions if we have any. Thank you. Over.
Merci beaucoup pour m'avoir accordé la parole. J'ai pas souffert pour avoir le micro. Merci beaucoup. Je suis Rémi Noy de la RDC. Ma question s'adresse à OMS concernant Spend Collect. Je voudrais un peu comprendre comment ça se passe au moment de déploiement d'un nouveau formulaire. Je prends le cas où on veut ajouter une nouvelle enquête et l'entité qui exprime les besoins doit vous contacter pour pouvoir créer le formulaire et le déployer, ou bien à partir de leurs experts maison, ils ont plutôt la possibilité, soit ils auront la possibilité d'accéder dans la plateforme Spend Collect, bien sûr, puis créer le formulaire, le déployer, comme ça se passe avec ODK, Kobo et autres logiciels, plateformes, disons, de collecte et gestion des données. Merci.
Can you respond?
Oui, merci beaucoup. Spend Collect, la plateforme Spend Collect, au niveau de l'application Android, elle est basée sur ODK. Donc, le formulaire ODK peut fonctionner sur ça, mais bien sûr, il y aura des spécifications qu'on sera obligé d'ajouter, qui seront propres à Spend Collect. La demande d'utilisation d'Spend Collect se fait au niveau du portail. Au niveau d'Spend Portal, il y a une page qui est réservée à Spend Collect. C'est là que la demande est faite. C'est là aussi que les spécifications du formulaire peuvent être faites s'il y a des questions qu'on peut ajouter. Nous avons des formulaires standards qui contiennent les recommandations de l'OMS qui sont utilisés par le pays, mais certains pays aussi demandent qu'on ajoute certaines questions qui sont utiles qui sont aussi utiles ou qui dépendent aussi des réalités sur le terrain. Donc, pour un pays, nous avons des pays qui sont habitués à utiliser ODK Kubo Collect, qui nous envoient des formulaires ODK. Bien sûr, ces formulaires contiennent toutes les recommandations pour une enquête de l'OMS. Nous pouvons utiliser ces formulaires et ajouter aussi des fonctionnalités qui sont propres à Spend Collect. Merci.
Thank you very much. And thank you very much to the presenters. A big round of applause as they leave the stage. So as we wrap up the session, before we break out for lunch, I'll call upon Robert to just introduce the product session that we're going to get into after lunch. Thank you very much. Over.
Thank you very much. I'd like to thank Ketty. She actually delivered us well ahead of time on this session. So thanks very much. I just have a few announcements before we hand over to Robert, and that's because we won't be gathering together as a large group until tomorrow morning. So to remind people that the cocktail reception is today at 6 p.m. near the pool. We'll start at 9 o'clock tomorrow morning in this room. For the cocktail reception, you have to bring this badge to get entry. And then I just wanted to encourage people to participate in the product solution session after lunch. So I'm going to hand over to Robert to give us just a bit more detail about that session.
Thank you, Jason. Can I have the slides? Okay, so for the next session, as Jason said, we have 2 sessions for today. The first one was focused on countries and other partners sharing experiences. The second session, which is after lunch, is mainly going to be on an exposure or an overview of some of the campaign digitalization tools. We've seen some of them mentioning the tools that they have used. So in all, we have 10 product solution partners who are here. For today, we will have an experience of 5 of them. Tomorrow, we will have the additional 5. In the first session that we are going to have, you have a group that is assigned to you on your badge. So if you can look at the badge, just at where I'm showing here. Sorry. On the badge, if you can find it, just right down there. The highlighter is not working, but we have the numbers that are assigned. So you have 1 to 5, 1 to 5. If you don't have a number there, please see your range. You assign you to a group, but we have 1 to 5. So we are going to have 2 sessions, 2 main sessions. The first session, we are encouraging that you go to specifically the number that is assigned to you. So the 1 to 5, I will show you on the next slide, each of the rooms. So if you're at number 1, please kindly go to the room that is assigned number 1. If you are number 2, you go to number 2. If you are number 3, you go to number 3. Now for the second session, you have the option to choose any of the product solution that you want to learn more about. You may either decide to stay there and learn more about it, or you move to another product and learn more about their product as well. We have also ensured that even after the sessions, they will still be available between 4 to 6 before we have the network reception. So if you don't have the chance to see and you can only see 2 at this time, you can still go to any of the rooms and meet them or have an experience of how these products have been deployed. Each of the session will last approximately 50 to 1 hour. We will have just a break. We'll come around with the bells and just alert you to move to the other session when we have the 1 hour. In between, whilst we are moving to the different rooms, the coffee will also be available. So you just grab your coffee and you just move to the next room that you want to experience or you want to learn more about. For today, there are 5 product solution partners. The first one is Digit by eGov, Red Rose, DHIS2, Across, and Comcare. And this is the order in which the number has been assigned. So if you have been assigned number 1, please kindly stay in this very room. So this room is divided into 2. The first session is Amasi 1. The second part of it, you see there's a breaker or a divider in the middle of the room. The second place is the Amasi 2. So if you are assigned number 1, you will stay in the Amasi 1 for the first one, which is eGov. If you are assigned number 2, you will stay in Red Rose for the first one. If you are assigned number 3, DHIS2 for the first one, number 4 and number 5 in that order. So the rooms, the first 4 rooms are here. So Amasi 1, as I said, is this one. Amasi 2 is the next one. Baobab 1 is just at where we have the coffee. The next one is after that. Zambezi 3 is on the 5th floor, and we have signage and the numbers on all the rooms. So once you step out, you'll be able to see the rooms that you have been assigned to. So please kindly take note of this. You can take a snapshot of it, but that's where we have the numbers assigned to all the rooms. So once you go out, you'll be able to see which rooms you are starting. So this is solely for the first run, which is almost 1 hour. For the second round, you will decide to go to any of these rooms, depending on the product of your interest. So if you want to go to, say, you had the first one in eGov, the second one, you can decide to go to Red Rose, you can decide to go to Comcare, you can decide to go to Across, depending on which of the products you really want to learn more about. This will be an opportunity for you to really ask more about the technical questions. I think the country level questions are related more on the operational related issues. But as you go onto the IT, the questions about security that people were asking, when you use personal devices and any other questions, it will be an opportunity for you to really ask. I'll just give a very brief overview on some of these products, but that's where the message that was sent across this morning as a reminder for the meeting. You have a brief that is embedded in that email that was sent. So once you look at the brief, you'll get to understand how the products are. But just as a brief, Digit, as they say, it's an end-to-end campaign tool, which actually helps you set up campaigns. It's used mainly for campaigns, helping you to do both registration and also distribution and real-time campaign data or dashboards. I'll not go into more details about this. So the product partners, please pardon me. We have sent a link for all to be able to read a link that have more details about how the product works, just to assist you or to help you to decide on which of them you want to go in the second run. For the other one, Red Rose is also a campaign tool. It works, is out of the box, support more than 45,000 devices at a time. It's also used for both registration, distribution, and also have dashboarding capabilities to help you do your campaigns. The third one will be DHIS2. DHIS2 also can be used for both campaign planning as pre-campaign, also for real-time monitoring, and also it has the functionality to support you for post-campaign. I think some of the countries have already presented on some of these functionalities already. The second one, which is Review or Across, which is the fourth product solution, can also be used for micro planning, that is mapping and also performing micro plans. You can also use it for the delivery of the intervention. So if it is about IRS or ITN, you can also use it to do that. And the last part is also helping you to visualize or to be able to do the data in terms of visualization. Is also linked to DHIS2. The fifth one is Dimangi or Comcare, also has a functionality of supporting you to perform campaigns. And one of the key features they highlighted is that it can also be used to do campaign payment, or it's a solution for campaign payments. It's been used for immunization campaigns, also integrated with DHIS2 and other tools. And it can be used also to do various campaign processes. So I think for today, most of the tools that we are looking at are tools that are more or less an end-to-end campaign platforms that you can really adopt for campaigns. Tomorrow, most of them are focused on either the micro planning or just certain components of the campaigns. So just to go back to that one slide, I think I still have some few minutes. So let me just repeat it for and clarify it. Okay. So if you're number one, you start with Digit, which is in Amasi 1, and that is this room. If your number assigned on the badge is number 2, Red Rose, which is on the second room. If your number is DHIS 3, you have Baobab, which is just over there, the first room, just at the coffee area. There's a second room, which is Baobab 2. We have put inscriptions on all these rooms. And then Comcare number 5, you're on the 5th floor. Please don't forget that it's on the 5th floor. So for the first session, as I mentioned, we will stay in these rooms that are assigned to us. But for the second session, you can decide to go to any of the rooms that you want to experience. And the focus of this, as I mentioned, will be on giving you the technicalities of it and also sharing with you some of the countries that it has been implemented, maybe the best practices that they observe among others. So with this, I think we will not be coming back to the main room after this session. So when you are going out to the video session, I think you can take your laptops and your bags because you will not come to the main room. And after 4, when we have done the 2 sessions, they are still available in the room. So you can still meet any of them if you want to engage any of them and learn more about the tools. So I think that's it. And thank you all very much. Hopefully we all meet here again tomorrow. Thank you. One last thing, please, it's not a napping time. So after the lunch, please kindly make sure that you attend each of these product sessions. Thank you.
Shall I change to that? Okay. So. Okay, I think we've received a lot of responses from the audience. As we can see, I think most of you have voted for looking at the dashboard, followed by multi-round capability and attendance management and registration and distribution using QR code. Just wanted to highlight, so for this demo session, we will be focusing on registration and distribution using QR code, and that will be followed by the attendance management and the dashboard. The multi-round capability, which a lot of you have voted for, we would like to do that as a part of our immersive demo, which is planned as round 2. Like at 3 o'clock, we're going to meet again, and that's going to be an immersive demo where we're going to ask all of you to download the application on your phones and try it out yourself. So we're going to do the multi-round campaign in that demo. So we'll be focusing on the remaining top 3 priorities in this session. Okay. Okay. So we'll start with the presentation. Yeah. Good afternoon, everyone. Good afternoon again. We are eGovernment's Foundation, and we are going to spend the next 50 minutes talking about the Digit Health Campaign Management Platform. So before we start the presentation on the product, who are we? Who is eGovernment's Foundation? eGovernment's Foundation is actually a not-for-profit organization that was set up 20 years ago to build digital public infrastructure to transform the way services are delivered to the public. And that's just one, building digital public infrastructure is just one part of what we do. We enhance network capability and catalyze the market ecosystem to drive this transformation. One of the first forays, our first forays into the public service delivery space was the urban governance. We introduced digital systems or digital public infrastructure to transform the way urban governance is delivered in cities and states in India. This was closely followed by the launch of the sanitation mission, the public finance management mission, and lastly, the health mission. I would like to talk about our achievement in the urban governance mission. So we have been working with the government of India for the last 6 years to develop a blueprint on how they should drive digital transformation in the delivery of urban governance services. So, and as of today, we have been able to get the government of India to commit a $180 million towards supporting the states to adopt digit platform in driving those transformation for urban governance. So as you can see, we have taken an India first approach for our urban governance mission, for the sanitation mission, and for our public finance mission. But for Digit HCM, we are taking an Africa first approach. We have been working with some of you here have also been working very closely with us. We've been working with NMCP in countries and other partners to build this Digit HCM application that is fit for purpose for the African market. With this, I'm going to now play a short video that is going to talk about the challenges that we typically face in health campaigns and how Digit HCM is going to help solve them.
Health campaigns are critical for delivering life-saving interventions across the world, especially in Africa, where routine health systems are still maturing. Health campaigns prevent millions of deaths and reduce trillions of dollars worth of disease burden. It takes months of planning, thousands of people, and billions of dollars to run campaigns. While digital tools are bringing about some efficiency, they are not doing enough. Coverage.
Yeah, sorry about that. A small technical glitch. We will have that playing now.
Health campaigns are critical.
It's not playing the audio.
are critical for delivering life-saving interventions across the world, especially in Africa, where routine health systems are still maturing. Health campaigns prevent millions of deaths and reduce trillions of dollars worth of disease burden. Health campaigns are critical for delivering life-saving interventions across the world, especially in Africa, where routine health systems are still maturing. Health campaigns prevent millions of deaths and reduce trillions of dollars worth of disease burden. It takes months of planning, thousands of people, and billions of dollars to run campaigns. While digital tools are bringing about some efficiency, they are not doing enough. Coverage still remains uncertain, and cost effectiveness a major concern. Current solutions don't seem to support the entire campaign cycle. Operations are fragmented from setting up to delivery. Coordinating is hard, stockouts are frequent, and payments get delayed. Different campaigns use different solutions, which often don't work together. And efforts like enumeration have to be repeated every year and in each campaign. This leaves the team stitching information across multiple silos, since real-time data is never available as it stands. Decision makers face an impossible choice. Digital tools are either free, but not fit for purpose, or they do the job but cost a fortune, taking money away from inventory, wages, and actual delivery. These realities made it very clear that point solutions cannot do the job. Health campaigns needed a holistic digital transformation. This is how Digit HCM came into being. HCM stands for Health Campaign Management, a free, fit-for-purpose open source product built as a digital public infrastructure to help countries transform health campaigns. Right from setting up campaigns to planning inventory and tracking delivery, it has all crucial components to simplify end-to-end operations and make decisions in real time. For national teams, it provides a digital headquarter to quickly set up and configure multiple campaigns, track progress with real-time data, and a centralized help desk to ensure that campaigns run without bottlenecks. Managers and supervisors get a co-pilot to run end-to-end operations. They can quickly track registrations and delivery, manage attendance and stocks, resolve complaints, make payments, and monitor progress, all from a single app. Frontline workers too have a digital partner, a mobile-first app that readily works offline, simplifies routine tasks with built-in data checks, easy navigation, and on-call support. It also ensures they get timely wages with smart payments. You see, when things are designed holistically, the entire system just works. And that's what Digit HCM does. It is not just another solution. It is built to be a strategic digital infra for public health, to enable high-speed transformations and new possibilities. Modular building blocks allow the same product to be reconfigured for different campaigns and diseases. And these building blocks can be reused to create new solutions in routine health, primary healthcare, and so on. Shared data registries provide a single source of truth from day one. All data of campaign staff, health facilities, and households can now be created once and leveraged across campaigns today and for routine healthcare tomorrow. Open APIs make it interoperable by default. No more worrying about siloed data or fragmentation. Digit HCM can work with any new or old system. As a true digital public infrastructure, it makes digital sovereignty possible, such that all data and digital product assets can reside within the country. And national agencies can decide the roadmap of health digitalization. Yes, that's why HCM is a game changer. It is open source. It is free. It is yours.
So, in a nutshell, if we have to describe what Digit HCM is, it is an end-to-end campaign management platform that can be used for multiple diseases and for multiple campaigns. As you can see, there are different stages that happens typically when we are digitalizing a campaign. And all of our features have been developed, features and capabilities for Digit HCM has been developed, keeping in mind those phases and how we can align our product best to each of those phases of campaign implementation. With this, I'm going to hand it over to Abhishek, who is now going to do the demo of our product.
Good afternoon, everybody. Thank you, Ranjani, for giving such an elaborate detail about Digit HCM. So before I begin, let me just give you an overview of how we are going to run this session. Based on your all of you have voted. First of all, we are going to start with how a registration and distribution in a BedNet campaign is going to work, especially using a QR code voucher. Second, we will go into the attendance management, that how different campaign workers who are part of different phases of the campaign, how you can manage their attendance. And finally, all of this data that you have captured in the application, let's have a look at how that is shown in the dashboard, and that can help you make real-time decisions. Let me just give me a minute. I'll just the system got disconnected. So for the interest of time, I have already logged in as a frontline worker, or you can say community worker in your own respective countries. So the scenario that we are going to play out here is that I'm a frontline worker, I'm going to a household, and I'm going to register that household first. And for this purpose of this demo, we are going to showcase how a registration and delivery is going to happen separately. So as for the interest of time, I have already logged in as a community worker. I know there are so many features that I would like to show, but let's just focus on how the registration is done. I'm going to click on beneficiaries. So here the system is asking if this person is already registered. Let's say I'm going to this particular household. The name of the household head is Abhishek. I'm going to register this, click on register new household. In this next screen, the data elements that you wish to capture for your country specific requirements can be configured. And one more thing, the GPS coordinates that with which you are able to see the location details in the dashboard is also captured in the screen in the backend, which reduces the complexity of the user to capture it by themselves. I'm just going to click on next. The date of registration is automatically populated. Let's say the number of members in the household is 5 or 6 in the house. Here, as you can see, the system remembers the name that I already entered and reducing the workload of the user. If they wish to, they can enter the ID, the age is I'm going to enter an age, and the date of birth is automatically calculated. Selecting the gender. And finally, I'm going to link this data, that all of this data, that is the household information, the individual details, all of this into a QR code. So there are some QR codes which we have in the screen currently. So this is a QR code, which you generally, when you go to a household, you print it on a voucher and you encode the information into the QR code and deliver it to the household. So as you can see, it has captured the QR code and encoded the details. If required, you can enter this detail manually also in case the voucher or the QR code is damaged. So I'm going to click on submit. And that's it. So that is the first part of the registration and distribution, that you have completed the registration. And in the next case, that is when the community worker is sitting in a fixed post or in a school or a health facility, and the population or the people whom you have given the voucher, they are coming to the fixed post to collect the bed, showing the voucher. So here again, I am going to the home screen. I am going to scan the QR code. And as you can see, the details that was encoded in the QR code now is shown in the application. So it says that this person's name is Abhishek. The ITN is not distributed yet. What is the age and other details that you already captured during your registration. So I can open this card. If I wish to, I can add more members in the household, and I can go to record delivery. The system is again one of the another example of the easiness of Digit HCM is the reducing the cognitive workload of the frontline worker. So the number of nets to give based on the number of people in the house is automatically calculated. Again, this you can be configured based on your country's requirement. I'm going to submit. And that's it. So from our experience in Mozambique also, the entire process, starting from the registration to the delivery, can be completed in less than a minute. That is close to 50 seconds. So that was for the registration and distribution. Moving on, before going to the next flow, that is for managing the attendance, I am going to log out as this user and I'm going to log in as a supervisor. So when you log in, this is same for any user that you are going to, that is who is going to use the Digit HCM. The boundary data and other information are automatically downloaded into the application. And from this moment onwards, that is until now you need internet. And after this, once the user is logged in, you are not going to require internet anymore. And the user can work in airplane mode, and this because the systems has offline capability. So now what you're seeing on the screen is the home screen for a supervisor. So they can manage stock, they can mark, they can reconcile stock, they can also manage attendance. So an attendance register can be configured for any event which is going to take part as part of any campaign. For example, if there is a training of the frontline worker that is going to happen, for which you need to mark attendance, that is set up as an attendance register with a specific start, end date, and the number of people. And you can also see in the attendance completion, if you see how many times you have taken the attendance. And the system can also suggest or tell you that you have missed marking attendance for these particular dates. So I'm just going to click on view attendance here. The date of session is shown. You have the capability to mark attendance separately for morning and evening session separately, or you can mark it for a single day also. This is based on, again, the type of event that you are going to have in your campaign process. So let's say I'm going to mark it for the morning session, and I click on mark attendance. So here, the name, sorry about that. So here the name of all the attendees is listed, and using a simple just touch-based interface, you can mark the attendance for each and every person. That is one touch that will mark them as P as present. Touching 2 clicks will mark them as absent. You have the option to add more fields on this screen where you can differentiate different people, because like we all know, in Africa or anywhere else, there are many people with the same first and last name. So if you have a unique ID in place, you have the option to add that also in this screen. So I'm going to mark Ramesh as present, Neeta as present, and here there are 2 Neetas, as you can see, and I can differentiate them by the unique ID. So I have 2 options here. One is I can save and save as draft and come back to the screen to complete and submit the attendance. Otherwise, you can just finish the flow here and click on submit. So that is all it takes for you to mark attendance for any event, whether it is a training event for a frontline worker, or it is an event where the community distributors, the actual campaign event where the distribution is happening. So those are the 2 flows that we want to, or based on all of your polls, we wanted to show. However, there is one more flow that you have all requested, that is the multi-round capability, which is valid in campaigns such as SMC, which we will cover in the next session, which will be more immersive, where all of you will get a chance to download the application in your phones and test it out yourself. So we will all help guide you for completing that. With being that said, I will move on to, so now that you have seen the different actors in the campaign, how their lives are being simplified using DigitHCM. Now, for all of you who are sitting here, who are going to manage campaign, the most important aspect is the dashboard, where you can view real-time data and make decisions based on that. So what you are going to see right now So dashboard is basically a decision support system where all of the data that is captured in the application, whether it is from the registration and delivery module, or if it is from the inventory management module, or the supervisor, or the attendance, or the payments maybe in the future. So all of this information can be viewed in the dashboard base, and you can configure the charts based on what is your requirement. So some example, I will not go very detailed into each and every widgets. Just at a high level, dashboard can be configured at a higher level, that is starting from a national level. The supervisor can drill down from the national to a province or a county to the final level of a village, and they can view the campaign progress at each of those boundary hierarchies. One of the main use of this dashboard during our implementation in Mozambique was the sync data. That is, you know how many users are created or who are out in the field, but most of the time they are working offline. So you don't want to make decision on the dashboard based on what the data that you're seeing. You want to know whether the act or the completeness of the data. So this actually helps you to understand whether all the users have actually synced into the server, and whether you should wait until the end of the day to have your review meetings. So quickly moving on to the maps, which is, I think, one of the most powerful tools that you all are going to be using in your campaign operations. So here what you are seeing is the green dots are the delivered households where the geo coordinates that you capture during the distribution is shown. The red ones are the points or the households where the delivery did not take place. So you can overlay. So right now I'm overlaying already a target households with the information that is captured in the campaign. However, you can overlay this information. Let's say you have a data set from open sources like Grid3, where you have a settlement map or a malaria concentration map or a vulnerability population map or an HIV population map. So you can overlay all of this onto this map and see whether your campaign efforts are going into the right areas, geographic areas. Right now, you are just seeing it as a single bubble, but you can drill it down to view it at a very granular level, that is at a household. So these are some sample data that we are ingested, but so I'm going to focus only on this area. So as you can see, there are around 266 households in this area. And each of these households you can find out in the dashboard map. So you can see that the delivery was focused mainly on the side of the road, and you have other households which are missed. And you can, in your mop-up campaign, you can target to go to those specific households. So this is one of the just many examples that or capabilities that you can do with the map. And just as a final map, I want to touch upon how you can drill down the data from a national level to the village level. So what you are seeing right now is the district of Mozambique. So this is some dummy data that we ingested. So each district that you can drill it down to the next level, that is the administrative post. From here, again, you can drill it down to the locality level. And the final level, whichever is your boundary, which is the final level, mostly it is a village. You can view it at that level. Same for, you can see the same data for households. And some of the other capabilities in the dashboard includes viewing the stock information, that is how long the stock can last in each of the warehouses. Do you need to extend your campaign? At the current pace, will you be able to meet your target? You can see using a predictive analytics configured in the dashboard. With that being said, I will just want to give you a preview of what is coming up in the next. As you know, the Digit HCM is an ever-growing product or a platform. So we already, what you're seeing right now is many of these capabilities are already in place. We have a campaign manager coming up soon where anybody with a limited technical proficiency can set up the campaign by themselves in a matter of hours. So this will be available in the very next few months. You can do micro planning using a GIS based so that your targets become more accurate. You can all the vehicles that are being used part of the campaign, whether for delivering bed nets or delivering materials, you can track that real time. You can track the materials that are going to be used in the campaign, such as your t-shirts, caps, stickers, etc. You can track that using Digit HCM. Payments is another module that will be built on top of Digit HCM. You can have in-app job aids where you can tell the campaign worker to go and visit this particular place. We will have an SBCC module and also telemetry to understand how the user is interacting with the application. With that being said, I'll just hand over to Ranjini again.
Thank you, Abhishek. And I hope you guys were able to see what you wanted through your voting. So last year, when we came for the AMP conference, we spoke about the concept of Digit HCM. We spoke about the capabilities that we would be building on HCM and how you can run multiple campaigns on HCM. As of today, we have done a successful implementation of Digit HCM platform in Mozambique. The pilot happened from August to September 2023 in Tete province in Mozambique, and that was followed by another implementation at Gaza for BedNet. And as we speak, we are in the process of implementing 2 other campaigns. One is an SMC campaign at Mozambique, and the second is a BedNet campaign at Liberia. With this, we hope that we would be able to prove the hypothesis that we've been talking about, running multiple campaigns on the same platform, and also supporting different strategies that each of those countries have adopted. So while we developed this product and then we implemented it in Mozambique, we learned a lot from the field. There was a lot for us to learn and see how we can enhance the product, or how we enhance the way we deliver the product as well. One thing that we saw real time was there was better decisioning that happened because of real-time data availability. We saw that, as you had seen in Abhishek's presentation, he showed you the dashboard and how we could drill down to the last geographic unit. So with that, we were able to see how the campaign managers in the country were able to take decisions on where they would like to extend the campaign rather than extending it across the entire country. We also saw that there was a 50% reduction in the time that was taken to register a household, register and deliver the BedNet. So this enabled the teams to spend a lot more time in doing SBCC related activities in the household. And we also saw that there was a 25%, I think in our earlier presentation that we heard from Mozambique, they had also spoken about it, that there was a 25% increase in the HHR and distribution targets. Like the targets were set at 40, but we saw that in most cases, they exceeded 60. So that was another, which showed that the people were they found it very easy to use Salama, as we locally call it in Mozambique. We also, in order to improve the accountability of the BedNets that were getting distributed, there was one functionality, the BedNet scanning functionality, which we had introduced in the last mile delivery. But what we realized during our implementation is, while technology can improve accountability, technology alone cannot solve the problem. We realized that we need to have proper SOPs in place. We need to have adequate training and proper methodologies for training to ensure that there is better adoption for some of these features. We also learned that SOPs are very, very important while we're talking about the products. Like, I'm just going to quote 2 instances that we learned from the field. So I think when we did our very first campaign in TETS, on the first day of the campaign, we started receiving a lot of complaints around how the application was not working. When we kind of did the root cause analysis of it, we realized that people had gone onto the field without logging into the application. And as we know, in some areas, the internet connectivity was patchy, and that prevented them from logging in successfully. So now it is a part of our SOPs. We ingrain it into everyone's system during the training itself, saying that they need to log into the application before they set out for the day. Similarly, I think another learning that we had through our implementations in Mozambique is that, on the first day of one of the campaigns, there was a lot of requests around new users to be created or users unable to log in. So now we have an SOP where on the last day of the training, we mandate it for every person who's getting trained to log into the production instance. So all of those issues which we are seeing on the first day of the campaign is already preempted and taken care of. Those are just few examples that come to the top of our mind. And by working very closely with the country, we have been now able to identify, other additional use cases. So we were focusing on few aspects of campaign delivery, but additional use cases around vehicular tracking, waste management, were things that we learned by working very closely with the country. Another thing that I would like to highlight here is there are different aspects that are involved when we are delivering or when we are enabling the digitalization of a campaign. And what we saw in Mozambique was from TETS, the campaign at TETS to the campaign at Gaza, which was about 1 month apart. It was, while the TETS campaign was supported by eGov, it was completely country-led by the time we reached the Gaza campaign. So that, which in turn, again, proves the ease of using the Salama application or the DigitHCM application. With this, I'm going to play another video, which kind of encapsulates our experience of implementing DigitHCM in Mozambique. Request you to sit back and enjoy.
In the battle against malaria, Mozambique found itself at the forefront. The Mozambique Ministry of Health, MISAO, recognized the need of transforming their approach towards their health campaigns, including malaria. The challenge, fragmented operations and lack of real-time data and siloed systems made reaching at-risk populations difficult. What was needed was reimagination. And this is how Mozambique did it. Digitalization is a free, open source health campaign management product. Locally known as Salama, it covers the entire campaign lifecycle. The first campaign was digitalization of the PEDNET campaign for malaria. Salama covered everything from initial setup and staff onboarding to inventory management, registration, service delivery, and real-time monitoring. For the NMCP team, Salama functioned as a digital headquarters. Managers and supervisors oversaw operations from start to finish, all within a single app. Frontline workers benefited from a mobile-first application. In August 2023, Block 1 of Salama rollout began in tech. Data started flowing, ensuring Salama's integration into the fabric of local health campaigns. The impact was immediate. Across Tech and Gaza, over 1.16 million households were covered. A population of 4.71 million safeguarded, and 2.61 million bednets found their way into homes. The entire team in Mozambique, architects of this success, dreams big. If Salama is the foundation for campaigns, it can be configured within weeks to run multiple campaigns in quick succession. Digital health campaign management, reimagining health campaigns, reimagining possibilities.
Thank you. I would like to call upon Dr. Condrino, if you can talk a few words on your experience of using Digit HCM.
Yes, good afternoon. I think the video was clear enough to show that the first mass campaign with the platform in Mozambique. So we are so excited because it's a process. We are building the platform together, and the feedback was positive, as you had the opportunity to see on this morning on the presentation. The feedback on the field was positive. There is some small things to improve, but I would say that we are on good way. Yeah, so our goal is just to move from the net campaigns for the other campaigns. We started already with SMC, and we'll see. Yeah, so we are so very, we hope that we'll have opportunity to come and present on next year to see that the platform now is integrated more campaigns than ITNs. Thank you.
Thank you so much, Dr. Condrino. We are now open to questions.
I must start by congratulating Mozambique for the successful ITN campaign using it, and also congratulate Eagle. Okay. I must congratulate, appreciate Mozambique for a successful ITN campaign, and also moving on to start the SMC campaign. And congratulate eGov too. One of the things that I am very happy about is that it will end up being open source. Whatever you document, whatever is kept, will be accessible free of charge on the long run to everybody. And that encourages sustainability. But I have a couple of issues I may need your clarification. Number one, will I be correct to assume you use the bring your own device approach? Okay, there are like 6 or 7 comments I have that you can clarify. Number one, will I be correct to assume you're using bring your own device? And if it's correct, what was your experience there? Number two, campaigns have different data points, and you definitely showed some of them. Many campaigns have different data points they require you to fetch data or to intervene or to support through digitization. Would Digit do this same thing for every kind of campaign that is going to run? Okay, thank you. Be able to do this for every campaign that will ultimately or finally be run on the platform. Number 3, different implementers at different levels. If you use ITN campaign, it's a different ballgame when you're doing maybe NTDs. When you're doing SMC, it's also a different ballgame. Now, not every implementer requires the same kind of or level of access. Can or is Digit segregating those levels of access so that somebody at the lower level, what he doesn't need, he wouldn't be able to access? Number 4, for attendance, for instance, I heard you mention unique IDs, and I wanted to hear also QR codes. But that's not my problem. My problem is it possible for Digits to use biometrics for the attendants or attendees? English is my second language. Now, for them to personally sign themselves, because the way you presented, it looks like some other person, you are the person ticking whether somebody came or didn't come. Now I can decide to log in my wife, log in my sister, log in. Now all my enemies, I just make sure I do not log them in. Is it possible for Digit to use biometrics so that we are sure that person himself or herself signed in? I am happy about the stamping, coordinates, and that are real time, that are automatic too. So that as this person is also signing in, the stamps are there. It's not I will sign against tomorrow today. I don't know whether I made sense in that particular question. And then also, all these campaigns that are different, are they going to be in silos, not speaking to each other? You are like chefs, you configure them in such of their compartments, you compartmentalize them. If I want to go, there is not, the analytics will not give me the kind of dashboard that enable me see, I may be looking at SMC here, maybe I'm the director of public health. I want to look at all of them together to see how they're doing. So that I will not be shopping from one facility to the other, or one department to the other, to look at some of our kind real time, look at this, make decision. The higher you go, the less time you have to go surfing through all these things. Then again, how many persons at a time can you accommodate? I'm a Nigerian. I'm looking at, I want to do campaign, a total of 25 million children. You did 22.61 million. I'm doing 23 this year. Will Digits be able to give me the platform to enable more than 150,000 people to use it at the same time without it crashing? And I think my final question is congratulations.
Yeah, thank you for your question. So your first question was regarding bring your own device. So probably I didn't show it in the roadmap, but this is something we are going to be including in our roadmap in the next few months. So even right now also, you can, as long as you have a mobile device management system, you can have it in the user's phones. You don't need to have BYOD. You can control the data access, data security, data accessibility through MDM software. But if you want to, let's say, host it in a Google Play Store and let everybody download from there, then BYOD becomes relevant, and that is part of our roadmap in the and we will communicate. I think we are all discussing with our partners on understanding the different requirements and use cases to ensure the data security. Second, I'm not sure the second question. Did you get that?
That's a bit sad. You might be able to finish it before we go to woodwork.
So, okay, yeah, on the same platform. Yeah, so I think, yes. So one of the things, if you see the product, the first landing page there gives you an option to choose which campaign you would like to run at that point in time. And then when you choose that particular campaign, the data fields will be customized based on that. But the thing is, all of those campaigns are still on the same platform, reusing the registries across those platforms, across all of those campaigns. So that is possible with Digit HCM. Yeah.
That's a great question. So it depends on how you want to run your campaign, right? So you might want to do the delivery of all the three in one. That can be set up as well. Or you can run it as three separate campaigns running in parallel because they're running in different parts of the country.
So it is a role-based access that is there right now. Hence we didn't get a chance to show that, but in fact, what we're doing currently in Liberia, the distributor is different from a registration person. So what the registration person sees is different from what a distributor sees. So role-based access is available in Digit HCM.
Again, it is same for the different type of the campaign. Like you can choose whether the person managing the NTD should be able to view the person managing the malaria campaign. So that also you can, the role-based access works for the application as well as for the dashboard. So you can control who views the data. I think the fourth question was related to the biometric unique ID. Yeah, so currently biometric is not there in Digit. However, we understand, so currently we are in talks for building the payments module, which is again closely tied to the attendance module. So your payments is going to be done based on how the proof of work. So proof of work is, like you said, I agree completely to you. It cannot be, unless you have biometric or a QR codes or some unique ID, you can never ensure the correct. There is always loopholes that correct. So yeah, we are taking out. I think during this conversation, we are getting this feedback, which is pointing more towards a QR code or a unique ID, and I think we will communicate to all of you when we will be able to deliver that such use cases in our and we'll include that in our roadmap also.
And then the largest number of people that can have access to your platform per time.
So I think we would be able to manage that large volume. In fact, in India, there are about 28 states which are using our Digit platform for the urban governance service delivery. And we all know the population that's there in India.
Yes, it depends on who is using that. You understand? If you're
the citizens.
Okay, the
citizens. It's a citizen-facing application. Okay, so we've been able to manage that volume.
Thanks.
Okay, sorry.
No,
yeah.
for people asking the question, you need to use the microphone, otherwise the interpreters cannot hear.
Okay.
Please, about the same question. As you say, you have many campaigns on the same platform, but the hierarchy of the unit, organization unit is not the same. When you are doing SMC and when you are doing Nets campaign, how do you manage that one?
Yeah, that's a very interesting question. So as Digit, I think I'll cover the question of shared registry of that having a single database that was included in his question as well. So we always advocate for having a maintaining a shared registry for different types of campaigns. So, for example, for Mozambique, we have used the same boundary set, like you are saying. For the first campaign, which was an LLN campaign, we have used the same registry or the same boundary hierarchy for the SMC campaign, which is going on currently. So the power of shared registries, of course, that for you to do any analysis, that as when you look at it at an integrated point of view, that how the different services that you're delivering, whether it is a bednet or an SMC, how that is benefiting the citizens at a integrated level. That is only possible if you maintain a shared boundary hierarchy and you maintain a shared registry. Shared registry is something that Digit anyway has, and you will be able to use it. Shared boundary hierarchy or boundary, that is always up to the country, whether how they want to advocate. But we always advocate for reusing the shared boundary hierarchy, which of course has its benefits that I think the Mozambique team also will be able to tell you.
Yes.
OK, on peut?
He's talking.
D'accord. Vraiment, on voudrait féliciter le Mozambique et féliciter toute l'équipe. Les résultats qu'on a vus, c'est vraiment attrayant, c'est très intéressant. Et pour ça, on va vraiment féliciter toute l'équipe et celle du Mozambique. Alors, mes préoccupations, c'est juste peut-être savoir quelle est la capacité d'hébergement de cette plateforme. Et supposons, par exemple, qu'il y ait beaucoup de campagnes avec beaucoup de données, avec beaucoup de pays sur la même plateforme. Est-ce que il y aura de la fluidité? Est-ce que l'application est vraiment à la hauteur de gérer des milliards? Quelle est la capacité de gestion de données de cette plateforme? Et également, la deuxième préoccupation, c'est surtout la protection des données, puisqu'il y aura plusieurs données de plusieurs pays sur la même plateforme. Comment est-ce qu'on prévoit la protection et surtout sur le droit de protection de ces données-là? Donc, voilà mes préoccupations par rapport à la plateforme. Sinon, vraiment, félicitations au pays et à l'équipe.
Thank you. I'll take that question. In terms of so I think there is a slight confusion. The platform and the tool is hosted by the country. So this, can we get French translation? Are we translating now? It's working? Okay, so I think there's been a slight confusion, which I'd like to clarify. We as eGov do not host the health campaigns management platform. So when a country signs on, we actually deploy it for them, which means that only your data is on that instance. So there is no question of multiple countries hosting their data together. The second part, in terms of scale, the way the system is designed is it can handle billions of transactions simultaneously because the system was developed and has been tested in India for over a decade, where currently there are about 250 million citizens in India who use services running on the same platform on which this tool is built. The last point around data privacy, a lot of the principles of data privacy are built into the system, which ensures that even things like reporting, we strip out any PII data which can identify individuals. And what you get is real-time dashboards with aggregation and all the best practices, whether it is, say, the data privacy laws of the EU or India or Africa are made available here. Needless to say, if there are any country-specific requirements, those can be added at the time of implementation. Thank you. Yeah, it's after that, sorry.
All right, thank you very much. Thank you for the great presentation. My question is, I've seen that when you were doing the demo, you showed that they can edit the data in the household registration interface. So is it a situation where if they can edit data, are there risks that you've encountered for people going back to change the data just because they want to change the number of nets that is meant to go to a household? Were there issues like that happening? And at what point is it that a person can no longer change the information within that interface? Then how do you track coverage? Because did you do a mapping at the planning level so that you can help the country see whether they've covered everywhere fully or there is partial coverage? Or are you just using GIS to just look at the place and assume based on the tracks of the mobilizers that these are places that have not been covered? How were you tracking that properly? Then finally, for the voucher, were you printing the QR code? Were you generating the QR codes and printing them? And if those QR codes are damaged, how do households redeem those vouchers for their nets if they are damaged before the distribution days? And are you thinking about having like a voucher that can be used multiple times so that it can be retrieved, then you use it again in another campaign rather than reproduce it every time campaigns are going to happen? Thank you.
Sure. Thank you for your question. So coming to the first question about whether you want to edit the details that once you are registered, I think the exact same situation was there in Mozambique. So we as Digit, we have the capability to configure any fields or make any fields mandatory or non-mandatory based on your requirement. Whether you want to edit it or not, it's up to you. For example, Mozambique, this was the exact issue that NMCP raised, PNCM raised, that they did not wanted to make the edit option available to the community distributor because which means they can increase the number of nets. So we removed that option. So that's how that Mozambique platform went live. Salama went live. Yeah, calculating. So whatever data that you are seeing in the dashboard, so the coverage is based on the targets, which is essentially coming from your microplan. So microplan, all the population, the households, the number of nets, all of this information you aggregate at a village level or whichever level that you can aggregate. Let's say the lowest level is village, then you aggregate it to the top. So in the dashboard, you can see which are the areas. For example, you have 5 districts. You can pinpoint to which village, how many more households need to be covered. So it is basically a comparison between how many have been registered versus how many are yet to cover based on your microplan numbers. So your microplan number is become the parameter for calculating coverage. Yeah.
Okay, to answer the last question that you asked about the damaged QR code. So this particular feature we are currently implementing in Liberia, and this is again a decision for the country to make. We don't make that decision. So one of the things that we learned from that country was they do not want to give out a bed net if they don't get a voucher. And they're going to handle that programmatically. But we are leaving it to the country. On reusing that QR code across multiple campaigns, again, if the country wants to do that, where they kind of use this QR code as a unique ID to identify a household across multiple campaigns, that can be enabled on the platform. But yeah, it's dependent on the use case that you would want us to implement, and that is possible. Okay. Oh, that's... Okay, but our booth is right outside. Please reach out to us. Our team is here for any questions.
Last question, and then we move to other rooms, right? None was last question. Okay, my question is about the requirement for the server and the more smartphone if the country want to host their own the data in their country. What is the requirements? And the smartphone, what is the minimum requirement for the user?
Yes, on the server requirements, we have done an analysis of what is the minimum server configuration that we would need. we'll be able to share that document with the countries as per their interests. In terms of the minimum configuration, Digit HCM can work on Android level 9 and above. But one of the challenges that we are seeing in our implementations is sometimes the mobile device management software that is used for installing the application across multiple phones are not compatible with Android 9. There's like few of them, not all of them, but some of them. Because of that, sometimes we are looking at a higher configuration. But from Digit HCM perspective, we support Android 9 and above. Okay, our booth is right outside. One more question.
Okay. Bon, I'm speak French, hein? Ok, moi c'est Demba Kandé. Je suis représentant de PAF, Masepa, du Sénégal. Félicitations pour votre présentation. Félicitations aussi à l'équipe de Mozambique pour la première utilisation. J'ai quelques questions par rapport à la technologie que vous avez présentée. La première question, c'est comment se déroule le recensement des ménages? Est-ce que le recensement, une équipe doit faire l'enregistrement des ménages sur le terrain, ou bien vous utilisez une analyse spatiale avec la classification d'images pour détecter les ménages éligibles? Ça, c'est ma première question. La deuxième question.
Allô? Je peux déjà répondre à cette question. Ils vont dans les ménages pour enregistrer les ménages. Ils vont directement au niveau des ménages pour prendre les données, pour l'enregistrement. Ils vont au niveau des ménages
Ils
pour...
répondent d'abord. OK.
Ouais, donc... Non, je répondais à votre question, la première question. Ils vont directement au niveau des ménages pour collecter les informations. Ce n'est pas avec les données spécifiques.
OK, c'est sur le terrain qu'on...
Exact, oui.
OK, merci. La deuxième question est que la plupart des pays utilisent le DHS2 comme système d'information sanitaire. Donc, toutes les données de routine sont incluses dans le système. Donc, avez-vous développé un logiciel ou bien un web service d'intégration de données entre DHS2 et votre plateforme?
C'est bon. Can you? Yeah. So currently, Digit HCM is integrated with DHIS2, but in the next few months, we will also be integrated with other ELMI systems like such as OpenLMIS and mSupply. So DHIS2 integration is there, so it's already in the platform. Yeah. But thank you so much. So we will move to other products presentation rooms, right? So that other people can also come in this room. Thank you.
This was awesome. Yeah, for what it's worth, I'm very impressed at the application. Yeah, couple of quick questions. What is the GIS data available for download? And then the other question is, you demoed and shared a lot about the mobile experience, and then as all that data is coming in, is there like a HQ computer view that you have, and can you maybe speak to that? Thank you.
Exactly. So let me go here to just mention the GIS part. When it comes to GIS, yeah, okay, no, I'm not good at this two-screen thing. When it comes to GIS, we have an export called GeoJSON that's through an API. So if you've got an ArcGIS license, now keep in mind this is big data. So it requires licenses for these GIS tools. You can take in the GeoJSON, or we have KML files, which you can download and pull into Google Earth. So there's a lot of different options. We also just have the lat long that you can export from the system and pull it in wherever you need.
And it's all point data? That
And it's all, yeah, based on
household?
satellite. It's based on satellite, and it's at the point where the person is registered, but also we're synchronizing the devices where there's internet every few minutes. So we actually see the trail of devices as they move around, and not only at the point that they submit a form, but we can also see where they are if they're in between forms.
Also, or that's separate?
It's tracked in the system, and so we can put it into a report. Right now, we just have it in maps, and it can be exported. Every data in the system can be exported. It's based on the choice of the implementer to decide what they want to export and how how they want to use it. And then the command view. You want to pull up? I'm not going to touch it. I'm going to get it wrong. That's the platform. And so the platform is the command view, but there's also the dashboards. That's also a command view. And so what we have is the platform is where all of your people really monitoring in the moment are using data in real time. They're saying this net card they're having a complaint, this net card isn't valid. They can go into the system and research who has this net card, was it already redeemed, what's the situation? So that's the platform that you saw at the very beginning of the demo. And then here we're using Power BI, but it can be any analytics tool, any graphic tool that you want to use, DHIS2, Tableau, whatever. And we just built a very simple dashboard that's integrated both ITN and SMC distributions here. Can be through Power BI Gateway, which gives you a larger ability to do more modeling with higher data loads. And it can be published on the web, or for many actors, they are having Microsoft tools internally, so they can publish it in their Power BI in their application spaces as well. So our role is really to help you use your data. So how can we provide the data in the way that you need it for the tool you're going to use? And if you're going to use also a tool that we are also using, how can we help you prepare that as well?
Great, thank you.
Thank you. That was awesome. Just two quick ones. So it's data, how do you link this to the existing systems, like the KHIS, this case of Kenya? And then additionally, how can I use this data? Assume MassNet happens every 3 years. Do I still have this data? Can I access it so that maybe I make decisions in the next campaign?
Yes, excellent questions. And my first question back to you, you want me to do? Is it through API? Is it through SFTP? Is it through you just want to download the data and upload it yourself? We take the specification from the receiving system and then we make it happen. For the other data, yes, data reuse is something that is done in multiple ways. One, it can help you with the planning for your next campaign, like you said. The other thing is that for things like SMC or other campaigns, which are annual events, you can actually keep the profiles of the people and reuse that. In ITN, you can also keep the profiles of the households and the settlements. They tend to be used less because every 3 years, maybe things have changed, and it's kind of a new census, right, for the country. But these, again, are choices by the implementer. More questions? End of day. Online, great. Go for it, Ochai. Do you want to read it out?
Yeah. So the person asks, can the system integrate with other systems like shared registries, in bracket, product master data, or countries, inventory management, or warehouse management systems to leverage products and stock data from existing systems?
Yes and yes. For the majority, this is done through templates, export, import. That's the easiest way and the lowest cost way, but we can also build integrations through APIs where necessary. And then you can track it in the Red Rose system only for the distribution component, or you can do some of the commodity tracking through the logistics chain as well. I'm sorry online that I can't get you the Turkish delight that we have. She's checking. That was it? Okay. Nowhere in the room. I want to thank everybody for coming today, and please do stop by our booth. There will be more candy over there, and we are happy to go deeper into the platform, into the applications, show you some different delivery mechanisms for ITN, go further into SMC. Please, we look forward to seeing you.